They got quiet, Michael, so I think we're supposed to start.
Okay, great. So good morning, everybody. Welcome to day 2. I hope you had an enjoyable day yesterday, including those who were still there about 2 a.m. around the fire. So we've got another really good program today. Thanks to the planning committee for setting that up. And we're just going to give you a bit more information about a few things relating to the NMSG. So I think we're going to go to the next slide. So, is that right? Yeah. So we can't thank people enough, to be honest with you. So I just want to go through again, thanking sincerely all these people who've made this meeting possible. It's a huge amount of work, not just during the actual meeting, but in pretty much the year leading up to it. So all of these colleagues, Liz, Gil, Laura, Larden, Grace, Marianne, Eric, they've all done a fantastic job. So I think we should give them a round of applause. Again, we just want to also stress how grateful we are and how great it is to have these partners in sponsoring the meeting. There's going to be some presentations later from colleagues in industry, and usually the science is really fantastic. So these are the platinum level sponsors, just to thank them, and the gold level sponsors. Then we've got the silver level sponsors and the bronze level sponsors. And so please do make a point of talking to the different sponsors in the area outside during the breaks. It's really, really good to do that. And I think Rick is going to make a point, and I am, of going round all of the sponsors. Yeah, thanks, Mike.
There may be a few sponsors that I haven't gone to their booths and said hello directly. So I'm going to try to do that today and tomorrow, or if I somehow don't get to you, make sure you come up to me to introduce yourself so I can say I met you. So thank you again.
Next slide.
Next slide.
So I think this,
did I skip?
Yeah. So
all right, new members. So just to explain how you can become a member of the NMSG. So we made this change a number of years ago. It's not individual membership. It's membership by your academic site. And so it's $500 a year, and it covers everyone at your site. All the PTs, research coordinators, physicians, everyone is covered. So you are in that. I've had examples where I know that one site's a dues-paying member, and then one of the healthcare professionals at the site says, "Well, I don't know if I'm a member." Well, you are a member, but someone at your site has to let Liz know if anyone's been hired, if anyone's been fired, and so we can keep a list of who are the members at your site. All right, okay. So that's membership.
So then, just to be really clear about the benefits of membership, so not only is it the discounted meeting registration, but we're really, really keen, as we said yesterday, to support junior investigators and to support colleagues who are trying to set up and get clinical trials funded. So this can include just brainstorming, where you contact us and we can have a session with members of the executive committee that have expertise in the relevant area, just to discuss a plan. We can assist in assembling a grant. Data management and statistical consultation are also part of what we can do. So we're really keen to support more neuromuscular trials, and it's not always the case that in your local centres there'll be similar expertise that's bespoke to neuromuscular trials, and so that's kind of part of the founding mission. When Birch set up the NMSG was to really support trials happening in neuromuscular disease, and that remains really crucial from our perspective. I don't know if you want to add to that.
Well, yeah, this list, some of the things on this list are free. You just get it as being a member. Like especially brainstorming. If you want us to pull together a group of of smart neuromuscular folks, PTs, coordinators, PIs to help you brainstorm an idea, we can do that. Other things, we have funds available that you can apply for so that you can get grant assembly help, statistical consultation with Mike McDermott. He'll do that gratis. But then the hope is that you'll use Mike's team and put him on the grant. But you don't have to. If you want a little bit of money to talk to a statistician at your site or at another site, we can support that too. You just have to apply. And so all this is on the website. I keep hearing that it's not real well known what you can get out of the NMSG, but I've been told it's on the website. Now, I don't do websites. Have I told you that before? Yeah. I've told you I don't do websites, but I've been told it's all on the website. And so, but if you have any questions, just ask me, Mike, or Liz, or anyone on the executive committee. Except Emma, who asked me this question yesterday. What do you get out of the NMSG?
Yeah.
All right.
Okay. Then you're...
Oh, okay. Yeah, no, this is the current NMSG member site. So look to see if you can find your name. Is it in alphabetical order? Not really. But so search the list, find your name. And I want to make a big point here. Where is... So it should say Brigham and Women's / Mass General Hospital. Oh, I see Mass General's a little further below. So Dr. Amato is officially out of NMSG jail. He paid his dues, so thank you, Dr. Amato. Yeah. But I think, aren't you in Mass General one site? You pay for both of them. So okay, they're out of NMSG jail. There are a couple in MSG jail that aren't on that I think, but I won't point you out. I do want to say, everyone on the executive committee, make sure that you're a dues-paying member, please.
Yeah, that's the clue.
That's a clue? Okay.
And we're very keen, I'm very keen, and I know Rick is, to grow the European and other sites. Obviously next year it's going to be in Italy, which is fantastic. As I showed you on the graph yesterday, when it's in Europe, we get a big spike of abstracts and attendance, so it's very popular, so that's great. And Valeria is organizing that next year, which is brilliant. Okay, next slide. So welcome new members. So LSU Health, welcome, and UCSF and Oxford. So that's great to have those new members on board. You're all really welcome.
And I know we have quite a few from UCSF here, and some from Oxford. Is anyone here from LSU this year? Yeah, I didn't see them, but they paid their dues, so.
Yeah, we definitely got Oxford and we've got UCSF, which is great.
Oh, and yesterday, this is to cover up a mistake yesterday. We had the slides of new members of the executive committee, and we left off James Lilliker. Where's James? Yeah, so James, we're making this up for you. I apologize. Thank you for serving on the executive committee.
I was so worried when I saw this photo. I thought, that's not James. We're going to make this worse by putting up a photo that's not actually him. But apparently
it is James, him. Yeah. Well, I noticed that our pictures in the program are like a decade old. Right.
Well, more than one decade.
Yeah. All right.
Okay, so this, we just want to make it clear that it is easy to submit a study to the NMSG. Just email Liz a copy of the protocol and letter of request. And the steering committee will review it. This could be after you've already had advice and input and brainstorming. And then we look at the protocol with the expertise of the executive and can then approve it as an NMSG study. And we're very keen to build the numbers of NMSG studies.
This is a little confusing, if I could just talk about this a little bit. So we talked about the services you can get from the NMSG. The other service you can get is just getting your grant proposal before you submit it approved by the NMSG Executive Committee, and then you can put in your grant that this is an NMSG study, which some grant agencies are impressed by that. Some may not be. So we like to have official, any of your studies, we'd like to have them sort of condoned, accepted by the NMSG. Even if you're not using our data centers or statistical or getting any money, it just increases the cachet of the NMSG from our standpoint, but hopefully also will help you get your grant. So that's what we mean by submitting a grant to the executive committee.
And I think you commented sometimes in the past, peer reviewers have commented it's a positive that this has been gone through in an NMSG process as well. So it may help your chances.
I've had that several times where they say, it's great, this is the NMSG study, and they still didn't fund it.
Yeah.
But they comment that it's a nice thing. All right, so this is interesting. This is studies that protocols have actually gone to the executive committee and have been approved. Many of these studies are done now. The most of our IBM study, I know we have a lot of the folks from UC Irvine here. There's a lot of posters from that study at this meeting. Is that study still active, Namita? Is it? It's still active. So yeah, because actually I'm on it, I think. The memantine study in ALS is over. Andrew and Salman, please get that article back into Muscle and Nerve by the end of the month. Tassine's eponema study that's done. That one's done, I believe. That's the Tassine study that's done. And then you can see the rest of them. So it's interesting. I don't want to bust you, Mike Haher, but all these studies that I'm looking were funded except for Mike's. So that's an example where he actually got a lot of help from Mike McDermott and the NMSG to get this really good proposal in. I think it funded. I've got a lot of those. And so then recently I had another comparative effectiveness pain study for peripheral neuropathy approved by the NMSG called Beat C-SPAN, sub-Q methotrexate for myasthenia, that was approved by the MSG. And then TAME is the memantine study, so that's old, but it was supposed to be phenylbutyrate and IBM. So all of those were approved by the NMSG. All were rejected by the grant agencies, so we'd like more of those submitted. And then all the Shark Tank winners are officially approved NMSG studies, and they're listed here. Oh, I see, PBA and IBM, and ketamine and ALS. Those are two that I'm still working on that are approved by the NMSG. All right. Michael, you do this.
The highlights for today, we've got sessions on neuromuscular disease on the body, so systemic manifestations, neuropathy, and clinical trial design. And we've also got the presentations from our industry partners, which we're looking forward to. And we've got the Griggs lecture later this evening, and then a group photo. So if you're coming to dinner, this will be served outside on the Duke Terrace, and the photo is just before that, I think, but we'll confirm that later. So that's the kind of plan for today.
I think if you signed up for dinner, there's sort of a set place, and Liz told me if you didn't sign up for dinner, there may not be room for you, but then you can eat where we just had breakfast and dinner last night. So you'll be fed, but you may not be able to sit in the outdoor area with the rest of the group. But check with Liz on that, I'm not sure. All right. Dr. Heatwell we added him to the program as late-breaking news. He's going to give a presentation today during one of the breaks at 2:20. So stay in the room if you want to hear that. Or maybe it's before the break. He's giving the presentation at 2:20, and then afterwards, during the break, he's going to be in a breakout room for those that want to hear more about his starfish project. And then there's industry presentations today that you can see here. Dr. Howard, Dr. Asher, Dr. Guptal are all giving industry presentations today. And here's some more industry presentations. Okay. And then this is a slide that that the team has been working on. for days. So I wanted to have a slide, and Bill David's going to show this again tonight when he introduces Merit Sokovitz as the next Griggs lecturer. I tried to put together a slide of all the keynote speakers that then transitioned to Griggs lecturers over the years, and we are having some gaps in our memory. So that first one is supposed to say 2007. So I actually do have all the agendas and programs from the MSG that the Rochester folks gave us going back to 2003. And it looks like 2003, 4, 5, 6, there actually wasn't a keynote. And I thought there was every year, Bert, but it's not in the program. And it looks like the first after dinner keynote that was actually in the program was Dr. Griggs and Dr. Rowland doing a talk that Birch called Lean, Kind, and Fat Cats, Surviving a Famine. So I don't think that's a political cat statement. I just think it's, not sure. I still don't know what that means, Birch, but that was what you did in 2007.
I actually remember that lecture.
Do you?
Yeah, that was about the challenge of, you go through periods where you get funding, and then you have often long periods where you don't get funding, and how do you have multiple kind of avenues to seek funding and different ways of trying to support yourself. It was a lecture really for young investigators about the dealing with the difficulty of not getting funding, because most of us, if we're doing well, 10 or 15% of our grants get funded, so there's a huge amount of effort goes into not getting funded, and it's about how you deal with not getting funded that is the real measure of success, actually. And that's what I remember that lecture very clearly.
It's very profound. Yeah. You remember it.
Yeah.
And nothing to do with being
I don't remember your lectures, but I remember.
Yeah, right. I don't think I've ever been asked to give away. So, just saying. Okay. So then you can see the amazing speakers that Dr. Griggs had in the early years. Lord Walton, Art Asbury, Bob Brown and Jerry Mendel, Dan Drachman. It's a pretty amazing list.
Yeah.
And then in my memory is that, as I said yesterday, Dr. Griggs turned the leadership over to me and Mike in 2015, and that was in Snowbird. And we believe that was the first official Griggs lectureship, but we can't remember who it was. Who remembers who it was in Snowbird in 2015? This is a lot of people give talks, but were they the after dinner Griggs? Like, it wasn't Greenberg, no.
I wondered if it was Dan MacArthur who came into the genetics lecture, but I'm not sure.
No one can remember. That's crazy. Yeah. So we do think, we were talking to Birch at breakfast this morning, we do think it was King Engel, spelled wrong, and Valerie Ascanis were the last keynote speakers that Birch brought. And you can see the rest. So tonight it's Merit Sokovitz, which we're really excited about.
Yeah.
Oh, is that it?
That's it. So
okay,
we just hand over.
Thank you for letting us do some. Oh, thank you. See, if you don't invite me to talk, I just get up here and talk anyway. So now I'm going to turn it over to Kathy Matthews from Iowa, who's going to be the moderator for this morning's first program.
Great. Thanks.
Thanks, Kathy.
That's focused on the non-muscle components of our neuromuscular diseases. And our first speaker is Dr. Julie Parsons from the University of Colorado, and she's going to be giving an overview of the non-motor manifestations, and then we'll go into some specifics. Thank you, Julie.
And I thank everybody for being invited to give this talk. These are some of my financial disclosures. And then I thought I should probably do some personal disclosures as well, because my perspective on this talk is probably a little bit different. So I started practice, I'm old, I started practice at a time when we really didn't have a lot of genetic diagnoses. So most everything we did was by clinical observation and description. I've been a general pediatric practitioner, yes, it's true. and worked in a variety of different settings. And then we have done multidisciplinary clinics in Colorado since 1989 is when our clinic started. And this ends up being kind of important because we cover a huge geographic region. There is no child neurologist in the state of Wyoming. Our patients come from Montana, which is usually anywhere from a 12 to 16-hour drive. And so we've seen kids in Colorado from all over the Rocky Mountain region, which really affects the way we practice. Everybody has their own particular situation in terms of their practice location. So for learning objectives for this talk, I wanted to be able to provide, to be able to provide comprehensive care to neuromuscular patients by knowing about non-motor issues and being familiar with guidelines when they're available, and then how do novel therapies now play into how we take care of patients. So why do we care about non-motor issues? And I really sort of thought this talk could be standing up and giving a litany of every disorder and the non-motor manifestations, which would be incredibly boring to me. So I'm going to be just a little bit more philosophical about this because I think this really is an important topic for us to think about as neuromuscular neurologists. So the why for me is because we want to take the responsibility to care for the entire patient and be aware of what these non-motor issues are in a variety of different neuromuscular disorders. Because patients come with a variety of complaints. They don't come with a label that says this is my genetic diagnosis. How do we recognize it? How do we help others to recognize it? And then with the advent of novel therapies, we have to be good at making diagnoses quickly so that we can treat patients appropriately with the new therapies. So I think our choice as neuromuscular neurologists is we decide, are we a primary care neuromuscular neurologist or are we primarily a neuromuscular neurologist? And that choice will be different depending on what your practice setting is. From my background, I am a primary care neuromuscular neurologist. I don't mind taking care of constipation. I'm just fine with ADHD. So it just depends on what you in particular are comfortable about and what your practice is like. Every single clinic may have a different approach or a solution to care. Some issues are general medical issues with neuromuscular patients that all of us are completely used to taking care of and cut across various diagnoses. And then some issues are just specific to certain diagnoses. In this room, there are experts in every single neuromuscular diagnosis, and you know your disease very well, but that isn't necessarily shared by the entire community. We need to be able to provide comprehensive care and know what to look for, and then disorder-specific guidelines might be helpful. So I thought it might be kind of fun to go through a few cases that I've seen, just for fun. So called, and again, I'm a pediatrician, so called in to see a week-old infant in the NICU because of seizures. On exam, the baby has some dysmorphic features and is hypotonic. So of course, you order an EEG and an MRI in the NICU. So this is the baby's MRI. And you can tell, even if you're not in pediatrics, that the ventricles are kind of large, that the cerebellum is maybe hypoplastic, atrophic, and the cortex is kind of simple. It tends to be a little bit soft. Maybe some might say it looks like a cobblestone kind of formulation. So this actually is Walker-Warburg, which is a dystrophloglycanopathy. And then this case is a 7-year-old guy who comes into clinic because of deafness and intellectual disability. His 10-year-old brother also has hearing loss. And on exam, he seems to have somewhat of a flat affect, doesn't have a lot of facial expression, has mild deltoid and triceps weakness, and he does have the hearing loss. His fund of knowledge is a little bit low for a 7-year-old. So this guy, FSHD. And this one was super easy because looking at his mom, it was pretty obvious what his diagnosis was. This one, it's not really a 26-year-old, she was really 17, but I had to have credibility with the adult neurologist. So 26-year-old woman who comes in for evaluation of possible restless leg syndrome. And of course, do a complete review of systems with your patients. And she reports that her voice is kind of raspy intermittently. She feels like she's having trouble breathing. Her primary care doctor has diagnosed her with asthma and has been treating her for reactive airway disease. On exam, which as a neurologist is thorough, She has mild foot dorsiflexor weakness and diminished reflexes. She's a CMT patient. And then a 14-year-old teenage guy is referred in from the cardiologist. So he has had a cardiac transplant because he had a dilated cardiomyopathy. And now his grandparents who are taking care of him notice that he's had some proximal weakness. He does have mild intellectual disability. His family history is notable for his mom, who had Wolff-Parkinson-White, but otherwise was healthy. But she did suffer cardiac arrest and died at age 32. On her autopsy, it was noted that she actually had a cardiomyopathy. Subsequently, his sister and he were evaluated. His sister has a cardiac arrhythmia as well. And this guy had Danon disease. So none of these patients really presented with, I have a muscle disease. They all presented with something that was a little bit different that you have to look at and then make that diagnosis. So for general health concerns, when patients come in as neuromuscular neurologists, there's a list of things that we go through. We all think about pulmonary, about growth, weight, bone health. I mean, those are pretty standard for every patient that we see. But we do have some opportunities to improve care. So we who follow these patients really need to be aware of the non-motor issues that they might have based on their diagnosis. And primary care providers might not recognize that patients have neuromuscular issues, so we need to be able to educate them as well about what presentations of neuromuscular disorders we see. So some disorders we're very familiar with, and again, my list is biased towards pediatrics, but these are patients that you see commonly, you feel very comfortable, you know what you're doing with them. Duchenne, you can kind of tell exactly what a patient looks like. SMA, you know what the issues are that you want to check with every visit. Myotonic dystrophy, pretty standard. I mean, these are pretty popular in clinic. And then there's some disorders that maybe you're not as familiar with. And again, I recognize that some people in the room are absolute experts in these disorders, but maybe FSHD isn't quite as common as DMD in a neuromuscular clinic for peds. There are some LGMDs that maybe are a little bit more challenging. The list of congenital myopathies and genetic diagnoses for congenital dystrophies, and then CMT. I mean, when a patient comes in with CMT, do you really know what the non-motor manifestation is? Do you know that you're looking for vocal cord dysfunction or intellectual disability or hearing deficits in these patients? Do you know by the number what you should be looking for? And the LGMDs, I think we're running out of letters now. Do you know which patients you really need to have see a cardiologist, or which you can say, oh, you don't really need to have that particular follow-up? So I think it's hard to keep all of this in your brain. At breakfast, we were talking about AI, and I thought, okay, that might be helpful to try to keep things on track. But I mean, it's a little bit hard to remember all of this now. FSHD, pretty standard. A patient comes in, you know what you're going to look at. But in peds, you have to say, geez, a kid could come in with hearing deficit, they could come in with an epilepsy, but it's really important in an infantile FSHD patient to have them seen for hearing and be evaluated. It's very important to have them seen by ophthalmology and followed closely, because we can prevent progressive vision loss in these patients if we know what to look for that is not related to muscle. So how do we provide the best care? So there are consensus guidelines in a variety of different disorders, and many of you have actually written these and helped with this. But as we see both in DMD and in SMA, the implementations of standards of care really have made a difference in terms of survival and arguably in quality of life. The guidelines are old for SMA, and many of the, I mean, it takes a lot of work to have consensus and to produce these guidelines, so it's hard to keep them really up to date. But all of these guidelines, to me, really should be a tool that ends up being modified, updated, changed, with items dropped, items added in as we go over time. But we do know that, particularly with SMA as a good example, that just by institution of the guidelines that were first developed, that we do see that there's a change in terms of survival and in terms of ventilation as just guidelines are introduced, no novel therapies or additional therapies. So they really can make a difference. In terms of Duchenne, it tends to be more complicated. Now, honestly, when a patient is coming in for a 20-minute appointment, you can't really truly cover all of these issues, but depending on the stage, the patient, your clinical judgment, it's important to just at least have a reminder of what you should be thinking about and how to provide this kind of multidisciplinary comprehensive care for better outcomes. So the standards of care with early diagnosis and appropriate multidisciplinary care provide the best opportunity for maximum benefit of both current standard and upcoming novel therapies. So how do novel therapies play into this? Well, access to the therapy now requires a genetic diagnosis. And when we have a genetic diagnosis, it's really changed, I think, how we understand a phenotype. So just think of like RYR, and think of the phenotype and the variability that you see within just that specific diagnosis. Patients who benefit from novel therapies with prolonged survival and function are now teaching us about non-motor manifestations, things that we didn't focus on before, we now have to really think about in order to provide the best care for our patients. And then novel therapies sometimes lead us to underlying disorders that we didn't know were really significant. And so you just think of the X-linked MTM story with hepatic paleosis and death with gene therapy. And so we learn still about disorders that maybe we think we understand, and we don't. So as Goethe said, we see only what we know, and we now need to broaden our vision and our eyesight in looking at neuromuscular disorders. So an example might be, we all know that SMA is a motor neuronopathy, right? I mean, that's taken for granted. But myotonic dystrophy is a systemic disorder, and we think about that as a systemic disorder. We know, we're very comfortable in terms of how we treat myotonic dystrophy. We know what some of the issues are that we need to look at and think about in kids and in adults with myotonic dystrophy. And we have some pretty specific ways of treatment with each of these disorders. So this isn't anything really new to us. And then we look at this disorder and we go, in animal models and in human models, this is a multi-system disease. Isn't that interesting? And that's SMA. And so SMA that we've thought about being just a motor neuronopathy, we now know really truly affects multiple organ systems that we have to think about. And so in young men now, we really do have to think about fertility issues. And little kids that used to be, having surgery and I think, oh, they're just frail, small little kids, and then they get severely hypoglycemic and not do well. Well, they actually end up having some underlying metabolic disturbance. So we really need to now think about these disorders as more broad spectrum disorders. And I'm really glad that, for instance, Dr. Sansoni is going to start to speak on cognitive issues in SMA. We never thought about this as being a brain issue. Our understanding was that SMA kids are all bright, right? There's no cognitive issue with kids with SMA. So I think these are new ways to think about and look at different disorders. So I think in terms of how we look at things now, the genetic diagnosis is just the beginning. And despite the fact that I am not a PhD, I'm not a basic scientist, I do think that clinicians really have a role in terms of going forward and helping to describe how we look at different disorders. We need to be observant. We still need to describe clinical findings. We need to come together to group those findings in this group of rare disorders. We need to question our own assumptions about disorders and diseases and keep our eyes open. And then we need to educate patients, other providers, and ourselves about the disorders. So most disorders do have consensus care guidelines to guide care, and most individual disorders will have a website. And honestly, some of them are just like pages and pages of guidelines. These are guidelines, so they're not mandates, which means that at least you can remind yourself about what it is that you might have to look for with a particular genetic diagnosis. And I think that that's really helpful. If we look at some of the utility of electronic medical records, we actually can create after-visit summaries that have some bullet points of education about a disorder or anticipatory guidance care, what needs to be done. And that's something that's very useful, particularly in our situation, with going out to care providers that might be in Montana, Wyoming, New Mexico, to help that provider provide care to help us along as well. And then I think creating a referral network for people who understand our patients, learn about these disorders, and are interested is really very helpful as well. Lots of different guidelines exist. Lots of different guidelines will continue to be modified. Again, most of them are consensus-based and not evidence-based, and that's an important thing to remember. So you as a clinician still have the responsibility to care for your patient the way you think best, but these are guidelines and recommendations based on usually expert opinion. So, in summary, patients are referred to our clinics to receive specialty care for their neuromuscular disorder. We do need to know the natural history, which is getting a little bit more difficult in some of the disorders where we're having novel therapies now, to know what the natural history is. We need to use best practice for care guidelines and provide primary neuromuscular care to our patients. The multidisciplinary care can be timed and adapted to disease-specific staged needs. Anticipatory guidance can help prevent complications and enhance the quality of life. Some patients present with non-motor symptoms to other healthcare providers, so we need to educate our pediatric and internal medicine and family practice colleagues to familiarize them with neuromuscular disorders, because we need to have those urgent referrals, we need to make diagnoses so that we're able to deliver these new wonderful novel therapies. And then evaluation of novel therapies with systemic delivery on non-motor disease needs to be ongoing investigation, and this is where I would plead for great collaboration between centers and providers in dealing with these rare disorders, because I think that provides the power then to be able to learn and to be able to understand some of these rare neuromuscular disorders. And then with fall coming tomorrow, I have to say I'm going to be excited to get back to Colorado and to enjoy the outside.
Thank you, Julie. I think we have time for some questions, so you can't disappear yet. Does anybody have any questions? So I have, go ahead.
It's not exactly a question. I wanted to congratulate, and I would like to comment on such positive approach to patients with rare conditions or others. I usually say to my juniors or so, I see patients, I don't see diseases. I see patients with certain diseases that are rare. And that's what we need to look at, is a patient overall. In your case, with that approach, you discover more things in rare conditions. It's very, very important, and also empower patients, their families, to tell us what else the patients have or are struggling with. That's the only thing I wanted to say and share and congratulate.
Yeah, I agree with you. And I think that empowerment of patients is really important, because it is frightening for a primary care provider in a rural setting to be able to take care of a patient. They become a little bit afraid of taking care of a patient. So just the usual general practice disorders they get nervous about. So I think that partnership is really important as well. I agree. Thanks.
Okay, thank you very much. And our next speaker is well known to this group, Dr. Valeria Sansoni. And she is going to be talking about the cognitive issues in SMA, an important emerging topic that I'm very interested in hearing her talk to us about.
Thank you for this opportunity. So, going back to what we just heard, so why are we talking about cognitive function in SMA? We all, or most of us, thought that individuals with SMA were smarter, and also neonates and infants did not survive long enough, so that we did not really need to focus on cognition. We had other problems. So I think there are a few key points. So first of all, because we know that SMA affects different ages, so is the cognitive involvement in the early onset SMA that we are starting to see a primary feature of the disease, or is it the result of the neuromotor delay? And we need to quantify and measure. So what's out there? Is this adequate for to measure the cognitive profile in early onset SMA. And we know that these kids have a reduced possibility to interact. The social background affects the way they develop, as we know. So to what extent is it our genes, or is the family, social, environmental context that affect this neurocognitive profile in the early onset ones? And then we are taking care of these patients, so we have to start thinking of rehabilitation programs already that can support cognitive development, or should we not? So this is basically, I'm gonna go through quickly to the pros and cons, because compared to other diseases, we're a bit behind on having a position on whether cognitive yes or no. So there's support for, as you can see here, that the cognitive involvement in the early onset SMA is actually a primary feature, and there's support for this because the SMN protein is actually distributed within the brain, and you can see there's details there. We're not going to go into these details, but just to show that there is actually evidence for this. And at the same time, we know that the very severe ones can also have structural abnormalities in the brain. So again, this is intrinsic to the disease. But also, we have reports, and it's also our experience, that there is actually a very heterogeneous way of seeing this, and there are patients who are actually not showing any type of neurocognitive problem, at least for what we are measuring and able to see right now. So it's controversial. And the IQ scores also seem to correlate to the neuromotor impairment. So they're really not really brain problems, but they seem to be correlated to the inability to perform and the way we quantify that. So it's still controversial, not as easy. And again, this is again stating this thing. This is to show that there are different reports supporting and sort of bringing us with problems as to how to interpret the findings. So the other thing is, so how are we measuring these things? Because we are actually using the tools that are out there to measure the cognitive profile in the kids in general when we are talking about kids. And they are usually very good standardized scales with good instructions, good normative data, and the pros and cons of each of the ones that you see there are quite clear to most of us. So why would there be a problem? Well, it's really hard to take into account the fatigability and the slowed motor performance in many of these tasks. So what we are seeing in the cognitive results may actually be a result of the extreme heterogeneity, and maybe there needs to be better tools, at least for some of the things that we're looking at, to account for the motor limitations that may give false results. And so there have been attempts to actually go through all the different results that have come up from the results in the tests in the literature. And again, it does show that probably there needs to be a more broader way of testing this, not just with one scale, but some patients may be more sensitive to some outcomes and some things to measure than different ones on different scales. And so again, even for the fatigability, that's really coming up very frequently, that it's something which is not reaccounted for, and again, the slowed motor performance. So this is to say that yes, we are now looking into these things. We're not ready to come to some conclusions yet, so I think there needs to be more time, and I think this is also the reason why the standards of care are not yet updated. With all these new phenotypes, there needs to be things that we can say, even though they're not going to be guidelines, but at least consensus. And I think we need to see more to come up with some conclusions. And again, here, there's very, I'm always, this is a bit more philosophical, but how much is really where we are and living that's affecting us, and how much is it really our genetic background. So I think this is hard to pinned down, but it's something that we always have to consider, especially now with all these mixture of ethnicities coming along. And so, again, the longitudinal developmental profile did see that there was a positive trend of improvement. So again, this shows that with the treatments and the improvement in the motor function, also in some reports, the neuropsychological profile did improve. So again, going back to what's first and what's acting on what. And so this was just to give a flavor of, I do not have the answer to what's the cognitive precise profile of in SMA, either kids or adults. So I will present some of the experience we have in the adults. We have sent out a survey amongst the pediatricians seeing kids, because we also see both kids and adults. But I'm not ready to present the kids data yet, but it's showing that many more kids, as they are growing and staying healthier, are developing problems in their personality traits, with even autistic features and extraocular problems in their movement. So that's going to be needing to be looked at into more detail. But for the adults, I'm presenting here just a sample of 49 patients, as you can see. These are all adults. You can see they're mainly sitters. And they have mainly 3 copies of SMN2, but there's representative with 2 copies too. And we looked at the IQ values, and of course we just looked at the subtests because we could not perform some of those requiring the motor function tests, and this is basically what we looked for. And this is just, we don't have to go into the details, but we did find that the IQ results in general were not different from the healthy control. So this is supporting, at least it's a small cohort, this needs further investigation, but it didn't really show much of a difference. And the SMA2 patients performed worse than the SMA3 on the perceptual organization index. This does not really require too much of a motor function, so that may be something to look into. So in general, we did not really see any correlation to the cognitive functions to the neuromotor and respiratory needs and the nutritional status. I didn't show that this part, but they were all independent results from whether they were on ventilation or not, or whether they were having trouble with swallowing functions. Actually, they were mostly doing well on these things. So this is the experience that we have, is that with the adults, we do not really see significant IQ problems. We're looking into more of the other functions, the executive and the visual spatial. But so far, we are confirming that in our experience, the adults are, at least a group of SMA 2 and 3 sitters, are mostly doing well. So we'll have to see in the long term what's going on. And I also wanted to share the experience of what we are, or what needs to be, I think, thought of to also account for some of the things that may be some features that are bothering our patients. And so we are working on using immersive virtual reality, and then what we have is an entertainment lab. And so we are using digital tools to allow training of some of the functions. Some of our, if we have like some visual spatial problems, and we know that the patients have a limitation with their proximal muscles, we're trying to see whether we can discriminate between the visual spatial problems and their proximal muscles by having two settings, so that they can maybe try to pick where they can reach the tools, and see whether they can recognize the spatial situations in the different settings, as you can see here, and also working with numbers and thinking and putting together actions of counting and choosing the right coins in the banknotes. And so we're doing this in a multidisciplinary way, going back to the need of doing things beyond the motor neurons. And these are the patient's experiences. And then also we are using AI to work on, this is for the SMA1 who have grown and who are on treatment and who are surviving. And we have included patients to work with an art program, which means that they had to learn and use their eyes or finger residual function to write or dictate notes for texts with an editor, teaching them how to write short stories for kids and adolescents. And it was, as you see, there was a structured program with 10 hours of dedicated frontal training, video recordings and retraining, revision of text by the editors, etc. And then they used AI to think the words and produce pictures. And why am I showing this? It's because I was very surprised, and if I had some thinking of these patients cannot really be smart as we thought, when I saw what they produced as written pieces of their text and the pictures they produced using AI by choosing the words and the phrases, and how this matched with, and they chose, and you know how this works with the AI programs, they refine their pictures. I think this is really making us think as to what do we mean by cognitive impairment and how much of this is really within the features of the SMA phenotype. Of course, these are selected patients. I'm not saying that there is no cognitive problem, but this is just to say that we're really not there yet to say what the cognitive profile is, so it needs to be further explored. We need to have good diagnostic and outcome measures. Maybe we need more liquid CNS biomarkers, neuroimaging. With these kids or adults are going through so many of the functional scales because we're trying to, of course, figure out what the treatments are doing. But I think we cannot leave out the CNS at this point. And we need to harmonize what we are collecting and what are we looking for, because otherwise it's going to be a bunch of information that not even AI will help if we don't get all the data points, and the same data points, of course. And we need to find a way of measuring or considering the social context and the environment where these patients are. Just think of the access to standards of care and the disease-modifying treatments. And the neurorehabilitation programs may have a role in improving this. So I think this is what I really wanted to share with you. And first, of course, thank my team and the neuropsychological team that I work with, of course, and Andrea Lizio for the statistics and the help with this. Thank you.
Our speakers are going very quickly, so we have time for questions. That was wonderful. I'm going to start with you went through the literature quickly, and you clearly know the literature deep in your heart and soul. Do you think early onset type 1 SMA has a a cognitive component?
Yes. I think it's a neurodevelopmental problem where the neurodegenerative is coming on top of it. I don't think we can define it yet, and of course it's very hard to measure. So we're struggling with the neuromotor abilities, the respiratory, the changing phenotypes. And so, but yes, I think there is a neurocognitive problem there to start with. In fact, the survey is first looking at the different pediatric centers and getting their first impression of, and then we're scoring, or we're counting how many are reporting extraocular movements. Some are reporting some kind of myoclonus. So it's hard to measure. And the autistic traits in an SMA, it's very hard to measure, but we are all seeing it. So I think we need to consider how to get hold of that and how to come up with some phenotypes. And
think this goes back to something that Julie said, which is we need to question our assumptions and, you know, be willing to go against the dogma if what we're observing is different than the dogma. Other questions for Valeria? Microphone's coming.
Thank you. That was really interesting. Do you think that SMA is in the vanguard? It's the first time we have got a disease that we're actually changing the trajectory. And if we are now seeing what you've just outlined in the surviving SMA ones, that when, hopefully, we treat our other conditions, we are going to expose the same thing. We're going to see things we just didn't see before.
Yeah, definitely. I think that the disease-modifying treatments are modifying the trajectories. I think, but it's not just me thinking, I mean, it's all the reports from everybody, even in the room, that it's, it really depends on when you start, when you are phenoconverting, and no matter when you start, it's also how you start. It's already, if symptoms are there already, the way you can change the trajectory is very different, and then there's other confounding factors. But yes, these phenotypes are emerging. It's already there in Pompe's disease, and it's already there in other diseases. And the more we get these patients walking, interacting, doing things, then I think these problems are coming out. What we have I think the important message is how specific are the findings to the disease, because I also had fun looking into the literature, looking at how many reports of visual spatial dysfunction had been reported in neuromuscular disorders in general. I think there is not one disorder in which these features have not been sort of pinned down as there's visual spatial problems. So I don't know, it needs, definitely, these phenotypes are emerging, but then we need to think as to what's the importance of the findings that we have, and of course, how to measure treatment effects in these domains, which is harder.
Other questions or comments? Okay, thank you very much. That was great. And our next speaker will be continuing on the topic of cognitive issues, although less an emerging problem and more something that we're aware about. Dr. Nick Johnson from Virginia Commonwealth University will be talking about cognitive involvement in myotonic dystrophy.
Great. Thanks for having me and talking about the cognitive involvement in myotonic dystrophy. It's been a great meeting so far. So this is really actually two talks because they asked me to talk about adult and pediatric myotonic dystrophy. And as you'll see, there are two different stories. My disclosures. So this is to kind of lay the groundwork, and actually Julie did a nice job of this, that there are a couple different surveys that highlight what's important to individuals living with myotonic dystrophy. So the first is that Christopher Project, which is a over 1,000 patient survey, and you can see kind of about top 2 or 3 fatigue and daytime sleepiness, which I think we're all aware of. But then cognitive symptoms like difficulty concentrating really start to come in around 9, 10. And then same thing in Chad's survey, in PRISM 1, fatigue and daytime sleepiness also highlighted as key issues for individuals living with myotonic dystrophy type 1. So, definitely a disorder, as Julie pointed out, with cognitive involvement. So the data I'm going to share comes from the Myotonic Dystrophy Clinical Research Network, which includes these sites here. It's about a 22-site network. And I'm going to refer to 2 different studies. So the first study is NDM1, which is a 22-center that's enrolling 700 individuals living with myotonic dystrophy. The data I'm going to present is on the first 597 enrolled, It has visits at baseline 12 and 24 months. The primary endpoints are the COG state, and then we're using the cognitive questions within the MD-High, and you can see the support down there. And then TREAT CDM is a 3-center study that enrolled 82 children with congenital myotonic dystrophy with visits at baseline 12 and 24 months. And there's a much more robust cognitive battery with a measure of IQ, Vinland looking at adaptive function, Brief looking at executive function, and then several measures that capture autistic features, and you can see the support there. All right, so the current baseline features within NDM1, about 42% male, by and large Caucasian. You can see this study enrolls any adults living with myotonic dystrophy over the age of 18. So you can see the breakdown in the study. There's about 1% that had congenital onset, 12% with childhood, 71% with adult onset, and about 4% with late onset or symptoms that develop over the age of 50. 97% were ambulatory. The repeat length there is about 288. The 10-meter walk time is about 6.4 on average. The composite strength measures pretty even there at 10.8. And then the hand opening myotonia time is on average is about 5.8 seconds. So what is the COG state? So this is a computerized assessment test measuring a whole bunch of things that you can see there: associate learning, psychomotor function, executive function, memory, attention, verbal learning, visual learning, and working memory. We like the COG state as an outcome measure because it is super simple. It is a computer that the study coordinator can provide to the patient. You do not need a neuropsychologist to administer it, and it's, like I said, it's in all of the languages of the different countries that that are in the study. And then the last point is that it does have normative values associated with it. So it's from a multinational study, this is a pretty easy way to start to look at cognition. There is a little bit of a catch. So I have to say, when Valeria and I were looking at these data earlier last week, the mean values there, which I'm not gonna, on the table there, are actually pretty normal. Every single mean value there is within the normal range. And that was a little bit depressing, actually, because I think that doesn't really reflect what we think about when we're picturing the myotonic dystrophy patients that we're thinking of. But if you start to break it out by looking at the Z-score, so the figure on the left is the Z-score with the normal value being 0. And it is a little bit complicated in terms of the testing because the scores are not always in the same direction. So I put an arrow there to tell you when the scores are better, which direction, is it better to be a lower score or higher score, basically. And when you do that, you can see that even though the mean value across the board is basically at 0 or pretty normal, these distributions are not normal. And so we did a latent factor analysis test to identify the different cognitive profiles underneath this larger population. And when you do that, you end up with 3 different cognitive profiles within this study cohort. And the red values there are ones that are below average or below the score range. This first profile here are individuals with a difficulty with psychomotor function, impulsivity, executive function, memory, attention, and verbal learning. This is much more consistent with what I think about sometimes when I'm thinking about the cognitive involvement in myotonic dystrophy. And then if you look at the number, though, at the bottom, you can see there's about 61 individuals who fall into this cognitive pattern. Profile 2 these are normal. These are individuals who had an average value across all with balanced performance. So this is a very average cognitive profile. And again, you can see there's about 60 or so individuals that fall into that profile. And then profile 3, a little bit surprising, these are individuals who are actually above average. So these are individuals who are outperforming the normal cognitive values in terms of less impairment in learning and working memory, and there's about 126 individuals in this cohort too. So I think one point there and this will come back as we kind of look at who's in each profile, is just a reminder that the individuals who enroll in natural history studies and likely into our future clinical trials are maybe not all of our patients in clinic with myotonic dystrophy. And so I think we need to be careful as we're designing clinical trials with an idea that they're going to be able to detect cognitive changes, that's not really going to be possible if individuals fall into this particular cohort. All right, so who's in each profile? You remember this is basically in order. So group 1 is kind of below average, group 2 is average, and group 3 is above average. And so the figure on the left looks at the relative percentages of the age of onset by the individuals. Not super surprising that our childhood onset, our congenital onset is really only in the below average or even average cohorts. But it is distinct that when you look at the percentages across the board, there's not really a difference there. There's not really a difference in terms of the cognitive profile based on whether or not they had childhood onset, adult onset, or late onset, particularly. If you look at their actual age, though, so if you, again, now go to the table, you can look at the mean age, and you can see that those in profile 1, which is the below average, were older than the other two groups. And then if you look at their function, either measured by a 9-hole peg test or the 10-meter walk time, they were generally more disabled. What that's telling us is actually that those who had more cognitive impairments, were more progressed in their disease, but that the actual age of onset was not particularly predictive of whether or not which cognitive profile they fell into. So there may be, some interesting points there. And then looking at education and employment, these are probably not too surprising to you, but those there's more people who were not able to work in groups 1, and then you can see declining percentages in groups 2 and 3. And then if you look at their maximal attained educational level, again, kind of working your way down so that, high school is that yellow bar, and then a higher level graduate degree is the pink bar on the far side, and it's kind of in between. And so, again, not surprising that those with the kind of the below average cognitive profile were in group, tended to have a lower educational attainment, and those with an above average, actually, there's a good percentage there who went to graduate school or some sort of equivalence. It's not really surprising, but it does fit with the overall idea that, some of these individuals who are enrolling in this study are actually fairly high functioning. So what are some preliminary conclusions from the adult side? About 20% of the cohort had a detectable cognitive impairment based on this computer test. And then on the other side, some of the cohort was above average. It was generally associated with other markers of disease progression. And so it may be age or disability related. And so, these individuals are this is the baseline data. They're enrolled in the study for a total of 24 months. And so, I think we'll get a better handle on progression over that time. All right, so I'm going to switch gears completely and talk about myotonic dystrophy in childhood. So this is a survey that we did a long time ago, which is just to remind those in the room that in congenital myotonic dystrophy, we really think about it as 3 phases, with an infant period characterized by acute respiratory failure, feeding difficulties, clubfoot, and hypotonia. These kids are really often quite sick. And then in childhood, the predominant features when you see children with congenital myotonic dystrophy really do focus on intellectual impairment, autistic features, ADHD, and GI issues, and that the adult features of the disease don't typically develop until adolescence or later. And so these are 2 data sets here, one from that survey that I just showed you, and one from work that was done in the Italian group. And you can see that across the board, when you look at kind of motor milestones and other features of intellectual impairment, that there's about a 12-month delay in terms of reported age of walking in those individuals living with congenital myotonic dystrophy as opposed to childhood or juvenile myotonic dystrophy, and that the frequency of intellectual impairment in that congenital cohort is about 45%, with many in congenital and childhood reporting a high frequency of ADHD and autism spectrum disorder. It's consistent across both studies. And this is, again, a busy slide, but here it's not so subtle. So, you know, the COG state data was a little subtle and hard to pick through. But here, looking at our treat CDM cohort, you can see that when looking at the IQ, the mean score is about 64, which is really quite low. When you look at measures of adaptive function, the mean score was 71, which again is really quite low. And then measures of executive function, which are reported there, was about 63, which again is really quite low. And then looking at measures of autism or autistic features, so using a questionnaire called the ASSQ, which is an autism screening questionnaire, and then a measure of social communication and repetitive behaviors, you can see that in this cohort, they did meet the criteria based on the ASSQ for autistic features, but that was not based on their social communication. That score was really driven by a combination of difficulty with their verbal memory as well as their repetitive behavior. So I think, you know, when you're seeing these children in clinic, while you may choose to classify them as autistic, they don't meet the full criteria. If you think about it, they don't have the same social difficulties oftentimes as you would see, you know, in more idiopathic autism. So, and then this is a graph here looking at the IQ, the brief as just a way of looking at the ASSQ, social communication, repetitive behavior, and looking at the green scores, the percent that scored into the average, the low average, the very low, and then the extremely low. So you can see, you know, again, looking at the IQ, a high frequency of very low scores there, and then going across, looking at the Vinland, the brief, the SSQ, and then, as I said, that repetitive behavior score. So here, like I said, the story is much more clear in the congenital onset group that cognition is clearly impacted. And when you look at correlations with other things, the point here is just to show you that it is really associated with the ability of adaptive function. So it's not particularly associated with other measures of motor function, but the only thing that's particularly associated with is how well kids are able to adapt and function in life. Here, looking at changes over 12 months, it's a stable, it's easy, it's all negative statistics because it's basically all of these outcome measures are stable over 12 months. So this does not appear to be a changing phenotype. It looks like this is a neurodevelopmental problem. So conclusions on the pediatric side, again, more significant cognitive impairment in children with CDM. It is associated with difficulty in adaptations, and it's stable over time. And I'd like to thank our funders of the network and, of course, all the investigators, particularly Valeria and Man Hung for helping with the statistics and the analysis, and then Carlene for reviewing it. And I'll take any questions.
Thank you very much, Nick. Birch?
So, very vast experience, very beautifully presented and acquired. You were implying this is a static encephalopathy. And have you looked at repeat length in the patients and in the parents to try to understand what the difference is? Because it sounds like they're also looking at things that might have happened at birth, you know, like APGAR scores, other things that you might be able to look at to see if there's something went wrong at the time of birth. Because you'd like to feel like there was a way to intervene earlier and do something to prevent the ones that have major problems.
Yeah, I mean, I think the story is going to be complicated, and the reason why I said so in the congenital data, what that would suggest is that it does seem like it's neurodevelopmental, that these features are present early on, and they do not seem to change. When we looked at associations with repeat length, we did not see a change in the different cohort, and then we looked at whether or not how long they required ventilation at birth, and that was not associated with any features. And then we've been using this kind of score, because in terms of how severe their congenital myotonic dystrophy, which is, whether or not they had all of the features, the clubfoot, the hypotonia, the breathing problems, and the feeding problems, and that also did not seem to have any association. I would point out, as I was alluding to on the baseline adult data, that there were some changes or shifts with age and not with age of onset. So that may suggest that there's a neurodevelopmental component and then there's a neurodegenerative component on top of that. So I do think it's going to be a little hard to kind of tease those different features out, and will require some more work.
Thank you. I just wanted to, thinking of prevention and starting early, we just put together our data on the effects of having a child with congenital or childhood onset myotonic dystrophy, and we looked at how many of the mothers or fathers who were affected and knew they were affected actually decided to go through genetic testing, and that was quite low. And so that's another issue there. So it's hard to get the parents want to know what's going on, and potentially if we did have a drug or something that we could act on, I don't know. It's hard with the parents also to get them to be aware of what would happen, no matter the outcome for the congenitals and the childhood onset. So I don't know, just a comment on how hard it is.
Yeah, I think, and maybe one more point, then and more questions. But in early congenital myotonic dystrophy, at least in the skeletal muscle, that's probably not fully repeat length driven. That's probably actually driven by DMPK expression. That's what it looks like in the skeletal muscle, that it's an expression of DMPK, and that as children age, the somatic instability, the disease develops more degenerative components related to repeat expansion at that point.
Nick, I just had two questions, and you probably answered one of them. One was in that first group that you looked at of adults, in the patients who had high cognitive function, was that at all related to repeat length? And the second point is, I think Dr. Griggs is right. I mean, when we think about the congenital myotonic kids, many of those kids are preemie, they've been hydropic, they've had difficult perinatal experiences that have to impact what their outcomes are. I mean, I think it's very difficult to just look at, maybe time of ventilation, because if you're looking at a kid who's a preemie, who's been hydropic, and everything they've gone through in the NICU, that has to impact as well, at least your starting point.
Yeah, I think that probably is true. I just, some like time of ventilation, for example, we know because we see kids from a lot of different places that is also quite provider dependent, right? So that some of that's influenced by kind of where the care is being provided. So we can keep looking further to kind of the early management of those children. So in the adults, we have not looked at it against the repeat length because we're doing that internally. Actually, Charles is doing that. And so we have some historical repeat data, but that's from a bunch of different labs. And so it's not going to be particularly meaningful until we get it all done in the same consistent manner.
Question. Do you have any thoughts about do you think the degenerative component is repeat length instability in the brain, which doesn't make a lot of sense because it's not turning over? So what do you think the possible degenerative component, the biological basis for that is in the adults?
Well, I think that's a really good question. I'm not sure that, I don't know that
Which is why I'm asking you. I mean, give me an answer.
We can wax poetically about that, but I do think that, the assumption would be that it is probably, either, I think it's probably being driven by the astrocytes or the white matter changes that you see in these patients on their MRIs, and so those do turn over, and so that may be repeat instability, driving additional splicing. And then what splicing events are driving those? An outstanding question.
I mean, that's the most exciting part, because if it's something that's progressive and potentially modifiable, that would be fabulous. So,
Yeah, I agree.
Any other questions? Yeah, Emma.
Can you think of any possible recruiting bias? I mean, how good do you think this sample was across Rio? Because I just only imagine that many myotonic dystrophy that might not want to do that, right? To be tested for intellectual. So can you comment on that, of how representative you think your sample is?
Yeah, I mean, I think I alluded to that, but it is a very large sample, and it's geographically quite diverse as well. I do think, people who are able to sign up and spend a half a day doing a study always tend to be a little bit higher functioning than those not. And so I think, and having tried to recruit these patients, they don't show up for their appointments, or they'll miss it. So I do think we have a bias towards those that are a little bit higher functioning. Absolutely.
Okay, great. Thank you very much. And for the last talk of this session, we're going to switch gears entirely now. So we're going to stretch our cognitive functioning as neurologists and switch to the heart, leave the brain and switch to the heart. So I'm happy to introduce Dr. Carol Whitleave-Weber from CHOP, who's going to be talking about cardiomyopathy.
Good morning. It is so nice to be here. Thank you to the organizers for inviting me to this wonderful conference. I really enjoyed learning about the history of this group and the history of this meeting. As far as purposes of disclosure, Charity mentioned that I'm a pediatric cardiologist, so this talk will be skewed towards my experience on the pediatric side. And what I really hope to do today is to give you a sense of what we're thinking and what we're doing for these patients. As we all know, the inherited muscular dystrophies are genetic degenerative disorders typically caused by variants in a single gene that affect striated muscle and result in progressive weakness and wasting. I don't have to tell you this as a neurologist. This figure I love, and I show this every time I'm talking on this topic, because as a cardiologist, this is very helpful for me to see and understand just how complicated the muscle cell is and just how many ways things can go wrong. Cardiac muscle can be involved with some variability depending on the genetic basis of the muscular dystrophy phenotype. The key and sort of the summary of this topic is that the onset and progression of cardiac involvement is independent of the development of skeletal myopathy, right? There's poor correlation between genotypes and phenotypes at the cardiac and skeletal muscle levels. And given this, it is very important for me to closely partner with my neuromuscular colleagues to really understand what the genetic diagnosis is of the patient they are sending my way. And this also highlights the value to me of multidisciplinary clinics. With regards to cardiac involvement in muscular dystrophies, we really think of sort of two distinct phenotypes, right? So the big heart that doesn't squeeze well, the dilated cardiomyopathy, and the heart that just doesn't beat right, whether it's too fast, a tachyarrhythmia, or too slow, conduction system disease. Dilated cardiomyopathy leading to refractory heart failure is characteristic of the dystrophinopathies, some form of limb-girdle muscular dystrophy, and congenital muscular dystrophies, whereas conduction system abnormalities causing heart block, arrhythmias, and sudden cardiac death are most commonly seen in myotonic dystrophy type 1, the laminopathies, and desminopathies. However, importantly, they may similarly progress to dilated cardiomyopathy and intractable heart failure in the final stages. And further, patients who have severe ventricular dysfunction are at risk for arrhythmia. So there's definitely overlap in these phenotypes. This figure represents the muscular dystrophies most commonly associated with cardiac complications. Of course, this is not completely comprehensive, but these are the muscular dystrophies we talk most about in the cardiology world. And again, my experience as a pediatric cardiologist really is skewed towards the dystrophinopathies. But what can we expect? With regards to the dystrophinopathies, thanks to large natural history studies like Synergy, like MD StarNet, and other large registries, we've really learned a lot about the natural history with regards to the heart, right? It's not a question of if cardiomyopathy is going to happen, it's when cardiomyopathy is going to happen. The heart is going to fail. We know that the risk of cardiomyopathy increases with age. When we think about patients who with Becker muscular dystrophy versus Duchenne, the actual the prevalence of congestive heart failure and the age that cardiomyopathy develops is similar. However, as you know, patients with Becker are much stronger for longer, and so they can present in heart failure. And so whenever we have a teenage boy, particularly who presents with dilated cardiomyopathy, we are always thinking about, could this patient have an underlying muscular dystrophy that we didn't know? The other aspect of the dystrophinopathies that I've learned much more about and been more proactive about is the carriers. There's many studies now, including one by Solheim et al. That I reference here, looking at female carriers of dystrophinopathy and the significant rate of cardiac involvement that they are demonstrating. I'm very fortunate that at the University of Pennsylvania, just across the street from me, Dr. Teresa Wang leads a dystrophinopathy carrier clinic that receives funds from PPMD. And so it's really nice to have this partnership and to be sure that I'm counseling the mothers appropriately as well. With regards to Emery-Dreifuss muscular dystrophy, the spectrum of cardiac phenotype is fairly broad. You can find case reports of different types of cardiomyopathy, but it's really the arrhythmic risk that tends to come to the forefront. When you look at autopsy studies from these patients, they have fibrofatty replacement of the heart that actually starts in the atria and works its way down. So the risk of atrial arrhythmia and atrial standstill is quite important to consider, and the risk of sudden death, of course. Limb-girdle muscular dystrophies. I don't know how you keep all of these straight. Whenever I read up on this, there's many different types, and I know that they get reclassified. With regards to the heart, there's some differing features based on the mode of inheritance. Cardiac involvement is most notably seen with the autosomal recessive forms. In particular, there's a high prevalence of cardiomyopathy among patients with LGMDR type 9. Lastly, myotonic dystrophy. Again, I don't see many patients with myotonic dystrophy. Those that I do, I partner closely with our electrophysiology team to care for these patients, given their variable risk of ventricular and supraventricular arrhythmia, as well as conduction system disease. When you actually look at the incidence over time of ventricular dysfunction, it is a real risk that tends to develop in the adult years, but it's not that high. It's really that arrhythmic risk, I would say, in conduction system disease that needs to be thought about when their hearts are being monitored. So what do we do? So what is the most appropriate timing of cardiac evaluation? Now, I put here first evaluation, time of diagnosis. I think what I want to stress here is the importance of these conditions, particularly using dystrophinopathy as an example. This is a lifelong condition, right? I very much appreciate being able to meet these families early on, to explain to them what to expect, to give them time to process the diagnosis, to understand what we're worried about, what tests we're going to do over time, and what therapies I'm likely to discuss with them. The frequency of follow-up also depends on what condition that you have. At this point, we are asking the dystrophinopathy patients to come every year, but I think when you start looking at all the muscular dystrophies in general, the follow-up recommendations may vary. I wanted to highlight a little bit about what are the tests that we are doing and what tests your patients can expect from us. It's pretty standard when you come to a cardiology clinic that will do an EKG and an echo. The EKG is looking at that snapshot of electrical conduction of the heart rhythm, the echo, the ultrasound of the heart, assessing heart function. And talking about rhythm monitoring, particularly with patients with myotonic dystrophy, Emery-Dreifuss, and any of the muscular dystrophies with significant dysfunction, the EKG is not enough. We need to understand what their heart rhythm is doing on a longer term basis, and so we will ask them to wear heart monitors for a few days, maybe a month. And we also now have technology. We have implantable heart rhythm monitors that I've used and our electrophysiology team has recommended in some of our advanced patients to really keep a close eye on the heart monitor. With regards to assessment of heart function, we're all familiar with echocardiograms and cardiac MRI. If you are in the neuromuscular space, the dystrophinopathy space, all the rage is the cardiac MRI. You know, the cardiac MRI is a very valuable tool. I think there has been this shift in suggesting that like we absolutely need these MRIs and we must do them every year. And I want to say that the echo still has a role. I think we need to be broad in considering how hard it is for a patient with muscular dystrophy to lay still for an hour, flat in an MRI scanner. And so I do think we use this technology interchangeably to understand the status of the heart and the heart function. With regards to follow-up, I do want to highlight guidelines, as has been mentioned in other talk, but particularly highlight the 2017 AHA, so American Heart Association Scientific Statement on Management of Cardiac Involvement Associated with Neuromuscular Diseases. This is where I actually took that first figure from. This is an excellent document. It's very comprehensive, and it really gives you a sense of what cardiac concerns for each of the neuromuscular conditions and what the recommended follow-up is based on all the data the authors had available to them. And of course, there's some more disease-specific guidelines, the care considerations in Duchenne as one example. So what do we have to offer these patients? We have heart medications, we have devices like ICDs and defibrillators, we have ventricular assist devices, and we have heart transplant. And I just want to highlight the therapies that your patients may be on and therapies that your patients may be considered for. And if they're not being considered for, I want you to know that these therapies are available and maybe they need a different cardiologist. So with regards to cardiac medications, this is pretty straightforward when we see ventricular dysfunction. This figure comes from adult heart failure guidelines. There's a lot of data on oral heart failure medication uses in adults with ischemic and non-ischemic cardiomyopathy, obviously outside of muscular dystrophies. And we've extrapolated that data and these guidelines down to how we manage pediatric patients with low ejection fraction. And this is how we would manage a patient with muscular dystrophy and a low ejection fraction. So if you have heart failure with reduced ejection fraction, in this day and age, you're on at least 4 medications, one from the class of the ACE-ARB ARNI, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor, which is a medication that has really taken the heart failure world by storm in the last few years, and then a diuretic if you're congested. So these are standard medications that are started and up titrated. We, of course, have some barriers in patients with dystrophinopathy, again, as an example, with lower blood pressure, how much you're able to push these medications. But patients with low ejection fraction should absolutely be on a combination of oral heart failure medications. If you take nothing else from this talk, I want you to take one thing, which is knowing about the ACTION Network and a registry that I'm going to tell you about. The ACTION Network, so ACTION stands for Advanced Cardiac Therapies Improving Outcomes Network, is a network created 5 years ago that focuses on pediatric heart failure and pediatric mechanical circulatory support. Within the ACTION Network, there's a muscular dystrophy committee, which I luckily and happily am part of the leadership committee of. And through this committee, we have built a registry of dystrophinopathy patients. And we are very proud of this, and we are very thankful to PPMD for supporting this so well. At this point, we have over 800 patients with dystrophinopathy in this registry that is prospective. So we have data that we've acquired at enrollment, and we are asking centers to submit data every 6 months on these patients. As you can see, our follow-up data is lagging behind. But this registry, we're very excited about all the data that we are collecting and how we may help drive trials, how we may help gather data on gene therapy. So we're very proud of this, and I want you to know about this. As far as centers represented, I just wanted to highlight, as we've looked at the first 500 patients in this registry, they came from 20 centers across the United States and Canada as well. The registry tends to be driven, or is driven, by the centers with the largest population of dystrophinopathy patients, Cincinnati and Nationwide being an example of larger centers. Again, through our committee, we have come together as heart failure cardiologists caring for patients with dystrophinopathy to say, how should we be using cardiac medications, not only in the presence of dysfunction, but prophylactically as well? I want to just highlight briefly some of the data we've started to pull from patients and just show you like how cardiac medications are being used. This figure comes from analysis we've done on the first cohort of patients who reached 1 year of follow-up. Over 90% are classified as Duchenne. Average age of enrollment was 19 years, and on average they had mild dysfunction. And we looked at their cardiac medication use over the first year. And what you can see here is a very high use of the ACE-ARNI class of medications, 95%, 74% were on a beta blocker, 84% on a mineralocorticoid receptor antagonist. The use of SGLT2 inhibitors is definitely picking up in this population of patients. We're starting to use it in the presence of dysfunction and starting to consider it, what other uses as well. So this is a evolving use of this medication. The prophylactic use of cardiac medication in Duchenne, I have to speak to. We have data both with regards to ACE inhibitors and mineralocorticoid receptor antagonists. The idea that if we start these medications early, we can delay the onset and progression of cardiomyopathy. Current guidelines suggest we should be starting an ACE inhibitor by age 10. I'd like to point out that age is arbitrarily selected, and we are definitely talking about, as a group, of like pushing this earlier. When is the earliest we should be considering these medications with regards to the ACE inhibitor and the mineralocorticoid receptor antagonist? We're using cardiac MRI in the young patients to sort of drive when we may consider the MRA. We're doing cardiac MRIs in these boys as soon as they can lay still without sedation. And we've just successfully done a cardiac MRI in an 8.5-year-old without sedation. So we're able to use MRI. But again, we know enough about the natural history. We know what's coming. I think we're definitely keeping an open mind, more open mind about the prophylactic use and how young to start these medications. This other figure I wanted to just highlight when we're talking about prophylactic use of cardiac medications and using them in the presence of normal function. Another look at our cardiac medication use. This is looking at cardiac medication use by ejection fraction. Using the term consensus-driven medical therapy is really, we're extrapolating data, goal-directed medical therapy from the adult world down to patients with dystrophinopathy. And we're saying when you have dysfunction, you should definitely be on these 3 medications. But what I want to point out is even patients with normal function, 47% are on a combination of these medications, right? So the ACE inhibitor starting young, the mineralocorticoid receptor antagonist, either starting based on age or if you're finding fibrosis before dysfunction. And beta blocker use, as you know, these patients have inappropriate sinus tachycardia. We're using beta blockers to manage that. Devices. Pacemakers and ICDs, which are an internal defibrillator. I want to highlight this guideline. This is recent. This was just published in the last few years. This is excellent. So the Heart Rhythm Society put together an expert consensus statement on evaluation and management of arrhythmic risk and neuromuscular disorders. Not only is it an excellent review of arrhythmic risk in these conditions, but it really works through, based on best evidence, what are the recommendations when devices should be considered. Just to highlight example, so a class 1 indication would be a patient should have. So as one example, a patient with myotonic dystrophy and documented symptomatic bradycardia due to any degree of sinus node dysfunction or AV block, permanent pacemaker implantation is indicated if concording with patient's goals of care and clinical status. So this is just one example of a device being used, but again, just highlights that it's important from a cardiology standpoint that patients are being seen by a cardiologist or heart rhythm specialist familiar with their heart condition. I want to talk about ICDs, and again, I want to talk about ICDs in the context of dystrophinopathy because we've been talking a lot about this. I want to say there's a little bit of controversy surrounding the use of ICDs. So with regards to the current guidelines, an ICD should be considered in a patient with Duchenne, Becker or limb girdle, with severe LV dysfunction, despite using guideline-directed medical therapy, if it's concordant with their goals of care. Generally speaking, with dystrophinopathy, at least where I practice, we consider an ICD when there's severe dysfunction and a history of documented non-sustained ventricular tachycardia. I apologize that this table takes up the whole slide, but I wanted to highlight our experience with ICDs and dystrophinopathy. You know, the important consideration for patients with Duchenne who have severe dysfunction is the ICD is supposed to shock a ventricular arrhythmia. The ICD senses a rate, it doesn't sense a rhythm. The issue with Duchenne is the patients are just as high of a risk of atrial arrhythmias, and so that can lead to inappropriate shocks. The other issue too is when you look at patients with Duchenne and non-sustained ventricular tachycardia, the rates that you see are not very high. With regards to the 6 patients we implanted with ICDs, I want to point out 2 things. One is that 2 patients had inappropriate shocks, one had multiple inappropriate shocks and a lead dislodgement, so that would be a complication. But I then sadly want to highlight that 3 of the 6 patients have died with devices in place, right? So they've passed away and they didn't have a shockable rhythm, right? So I'm not saying I'm against ICDs in these patients, but I counsel patients that I don't want to provide this like false sense of security because there are other cardiac reasons why. The hardest one for me was my most recent, which is the last one, you know, because he had, you know, it was a brief atrial arrhythmia, you know, he passed away in the car. And so as you can imagine, for the parents who think they're doing everything for their child, and then this happens. So we should still consider these devices, but keep in mind how they work and apply to patients with dystrophinopathy. Ventricular assist devices, or VADs, a picture here is the HeartMate 3, so that is the device we use for adult-sized patients. I want to highlight this review by my good friend, Dr. Deep Nandi. He used the Action Network's VAD registry to look at how VADs have been used in patients with muscular dystrophy. So I want to highlight this. There were 18 patients with muscular dystrophy in his review, the majority with dystrophinopathy. And the way we use ventricular assist devices, we call it a bridge. So we can bridge you to recovery, we can bridge you to heart transplant, we can bridge you to decision, or we can use it as what we call destination or long-term therapy. And what you can see here is if you look at the patients with Emery-Dreifuss and limb-girdle who had ventricular devices put in, of those 6, 4 went on to transplant. But if you look at the patients with dystrophinopathy who had ventricular assist devices put in, it's much less likely that they will be bridged to transplant, and I'll talk about that in a second. But I want to highlight just the duration of support some of these patients have had, years of support, years of quality and quantity of life. And I do think that there's value in appropriately selected patients in using ventricular assist devices for long-term therapy or as a bridge to transplant. At CHOP, we have done this once. We have a wonderful young man with Duchenne muscular dystrophy who's been on an LVAD for 6 years. He came to us asking for this. Another center wasn't able to offer it. He has upheld 2 jobs. He is the highlight of our clinics when he comes in and we talk about the Eagles and tailgate parties and fantasy sports. And you know, when we first implanted him, we were like, well, we'll just take care of you forever. But he's turning 25 and we're pediatric doctors. And so I do think we're gonna transition him to the adult space. So again, in appropriate selected patients, I do think there's a role for this technology. Heart transplant. I love this review. This review is very timely, not only for this talk, but a conference that I'm going to next week. So this author did an excellent job with this review. Is cardiac transplantation still a contraindication in patients with muscular dystrophy-related end-stage dilated cardiomyopathy? This review is quite the tour de force because they essentially synthesized all the publications on transplant and muscular dystrophy. They put together a review of 290 patients, and I think you can see the breakdown of different muscular dystrophies, but I want to highlight the highest percentage is Becker muscular dystrophy, and Duchenne is that little blue bar. So, you know, historically, Duchenne patients have not really been offered a heart transplant, and this review really questions that sort of in general, because when they looked at outcomes for patients with muscular dystrophy who were transplanted for dilated cardiomyopathy, their outcomes were similar to patients transplanted with dilated cardiomyopathy that did not have muscular dystrophy. I want to let you know about this conference that's happening next week. So Parent Project Muscular Dystrophy is supporting this conference, and it is a conference looking just exactly at this. So expanding access to heart transplant, focused muscular dystrophy, and by that is really focused Duchenne muscular dystrophy. We've been offering patients with Becker heart transplant. It's really how to think more broadly about patients with Duchenne muscular dystrophy, particularly in this era of different therapies, extended survival, et cetera. So I'm really looking forward to this. When we looked at the dystrophinopathy registry through ACTION, just looking at advanced therapies, just want to give you a sense of what the numbers are. If you look at the first 500 patients in the registry, we have 8 patients with ICDs, typically implanted for severe dysfunction and a history of non-sustained ventricular tachycardia. We have yet to have an appropriate shock from an ICD in a patient that we're following in the registry. So I should have mentioned that when I talked about ICDs in our experience, right? We have not appropriately shocked someone out of a ventricular rhythm. With regards to LVADs, we have 6 patients in the first 500 that we're following. We have 800 patients now, so these numbers are all going up. Heart transplants, just 3 that we're following in the registry. So what's new? Well, I can't give this talk without talking about gene therapy. As everyone in this room knows, the expanded label for Elevidys and Duchenne. And to summarize my feelings about this in emojis, when you read the FDA summary, which I had a nice glass of wine and I did that, and what the committee thought about this, and then how the decision was made, and in talking to all my friends in the neuromuscular world, everyone's like, whoa, we weren't really expecting this. But then I'm often asked, hey, Carol, can you meet with this family and talk to them about the risk and benefit from the heart standpoint about this? And I'm like, sure, but what do you want me to say? Because we're still learning, right? So it's been a fascinating journey for the last year, and I think it will be moving forward. So what do we know? Well, Sarepta has shared with us, they've dosed over 200 patients. There have been 3 cases of non-fatal myocarditis. Other gene therapy studies have had fatal cases, not in this study. And I've been able to meet with friends from Sarepta, and they've been starting to share some of their troponin data and their echo data and their MRI data, which I'm always happy to hear. I would love to see some of that published. But so no fatal cases of myocarditis. Over the last year, when the label first got expanded for 4 to 5-year-olds, we've dosed 12 patients. So I just wanted to share what we're doing, what we're seeing. It's been a fascinating journey. So as you know, these patients are followed with blood work, including a troponin. And just to orient everybody and remind people what troponin is. So cardiac troponin, T, C, and I, 3 types of troponin, are proteins within the cardiac myocyte. Their function is not really relevant right now, but what is relevant is troponin is released into the bloodstream when the heart muscle is damaged. These patients, as part of the protocol for gene therapy, are getting troponins checked. So they have baseline troponins, and they have troponins checked with some regularity, depending on your protocol after. So just talking through what we've seen from a cardiac standpoint for these very young patients. So of the 12, 7 had normal troponins and normal cardiac testing. These patients are also getting baseline EKG and echo serially after gene therapy. 7 were totally fine. We had one young boy who was 5 who, at his 1-week cardiac evaluation, he had a decline in his heart function. It was just mild, but it was new. We did not admit him to the hospital. He actually never had an elevated troponin. We treated him with enalapril, and over serial echoes, his heart function has improved. I've not yet done a cardiac MRI on him. Mostly he responded very well to the medication, but at some point he will get an MRI. The troponin journey has been very, very, very fascinating. So much discussion about troponin. I want to talk about 2 cases in particular. So we've had 4 patients who have had elevated troponins after they received gene therapy, and this is a troponin I coming specifically from the heart muscle. We've only had 1 patient who had an early bump in their troponin on day 3. Their baseline was normal, and I should say our reference range for our lab, we do not have a high sensitivity assay. It's troponin I, and the reference range would be above 0.03, would be elevated. So this, the 4-year-old's troponin was normal. It bumped on day 3. The patient was completely well. There were no symptoms. EKG and echo were normal. This patient ended up getting admitted for observation, really just because of the anxiety surrounding the early troponin rise, and it came back on a Friday afternoon. I probably would not have needed to do that if it was a different day of the week or now that we've learned more, but this patient came into the hospital hospital. The troponin came down a little bit, and this was just a couple weeks ago, so it hasn't normalized yet. The patient is still doing well. So again, the long-term significance of this, I don't know. But we've had three patients who have had this later rise in their troponin, and two of these patients caused a lot of anxiety. And they were both dosed when they were 5. They're both now 6. The patient on the left, these are all the troponins. He had an elevated troponin to start. It normalized before he received gene therapy, and it bumped around 2 months out. There was a lot of concern that he was having a cellular immune-mediated response to the vector because his GGT was elevated. He was on oral steroids, then on high-dose oral steroids, and he ended up getting admitted where that arrow is. The troponin was 0.74. I did not think he needed to be admitted specifically for the troponin, but it was the combination of labs where the neuromuscular team admitted him, and he was on IV steroids. And then it was fascinating. So the troponin came all the way down. They asked me what I wanted to do. I said, please stop checking the troponin. They kept checking the troponin. The echo was normal, so he had normal echo. The patient, again, no cardiac symptoms. But when the troponin bumped, it bumped over 1, which was a sort of dramatic elevation. So I didn't really know what to do with that. So I did a cardiac MRI. Now, I didn't have a baseline cardiac MRI. I had his first cardiac MRI at age 5 after gene therapy, and he did have fibrosis. Did he have that? So that was interesting, because this is myocardial injury, right? This is troponin, it's coming from the heart muscle. What is the long-term significance of this myocardial injury? I do not know. He has, as I mentioned, a normal ejection fraction by echo and MRI, but I did start this patient on an ACE inhibitor. The patient to the right, he similarly bumped his troponin 2 weeks out. He responded to a higher dose oral steroid, which was then tapered down. But if you just look at this fluctuation, his troponin normalized and then it rose again. He is getting a cardiac MRI that's scheduled for, I think, next week. And I don't think I've started him on an ACE inhibitor yet, but I will. And so that's how I've modified my practice. If I'm seeing these elevated troponins, I'm using cardiac medication. But I think this is just very interesting to me to learn so much about troponin because, truth be told, I have never prior to this checked a troponin in a Duchenne boy at age 4 or 5, and I really haven't been doing cardiac MRIs that young either. So I'm learning a lot. So what we don't know is really how gene therapy will alter the progression of cardiomyopathy. This is a journey that I'm excited to live along with you all and help guide our patients as best we can. Oh, I'm done. I'm almost done. Okay. Last thing, just want to give a quick shout out to the protocols we use to follow these patients. Through the Action Network, we are trying to publish this. So basically, we do baseline cardiac testing depending on risk. So we consider patients to be lower risk who have normal function, no history of fibrosis, no history of arrhythmia. They are followed with troponin levels and cardiac visits. The cardiac visits are 1 week, 1 month, and somewhere between 3 and 6 months after. If all is well, we then go back to our annual follow-up. What we've talked more about now that the label is expanded is what to do with the higher risk patients, dysfunction, arrhythmia, fibrosis. We're making sure we have baseline testing sort of closer to when they receive gene therapy. For our older patients, we are asking them to have baseline cardiac MRIs, and then we're just following them a little more regularly after they receive gene therapy. I suspect that we will continue to alter this recommendation as we learn more about it. So with that, I want to thank you for listening to me and want to highlight for any runners that may be here, there are very lovely places to run, including along the bridge across the water, and it is very lovely. So I encourage anyone who wants to get outside to go check that out.
We are right at break time, so we'll take one question and then Carol's available during the break.
So in patients with cardiac failure, there often is respiratory muscle failure as well, and cor pulmonale can cause a dilated cardiomyopathy. Do you recommend monitoring for hypoxia in patients who appear to be developing heart failure?
Monitoring for hypoxia, you know, we work very closely with our pulmonary colleagues on this. I defer to sort of their assessment of respiratory function and respiratory strength. Obviously, in the Duchenne patients, they end up being on positive pressure ventilation overnight. They're getting sleep studies. I haven't really seen any like overt signs of pulmonary hypertension by echo in these patients. I think the patients that are best supported with positive pressure tend to do the best overall, but we haven't really seen overt pulmonary hypertension and right heart failure from respiratory insufficiency, at least in my pediatric experience. But so I haven't made, you know, recommendations for pulse ox monitoring overnight, and I really defer to our pulmonologists on that.
So I've seen patients who have been admitted for cardiac transplantation who, when you monitored their oxygen, found it was low, and by giving them oxygen and treating their respiratory failure, their so-called terminal cardiac failure resolved.
Well, I would, just to add to that, I mean, positive, so you're talking the right heart and the left heart. Talking about positive pressure ventilation and afterload reduction on the left heart is definitely a thing. And I do think that patients who are better supported from a respiratory standpoint, I think that absolutely helps their cardiac status. And I stress that when I meet these patients, that their respiratory support is essentially cardiac medication. You know, and talking about elevated pulmonary pressure and right heart failure, a little bit of a different clinical picture, but yes, respiratory insufficiency and hypoxia unmanaged will absolutely make the heart worse.
Okay, thank you very much, Carol.
All righty, that concludes the session. We're going to take a 10-minute break, and we'll see everyone at 10:15.
All right, let's go ahead and get started. We have one really great session before we head to lunch. So my name is Dave Arnold. I'm going to be moderating this session on neuropathy. We have quite a range of topics actually today. So we're going to kick it off with Dr. Pietro Frada. He's going to talk about cryptic splicing from foe to friend in tackling ALS and IBM. And he's promised he's going to stay on time, so let's see if we can hold him to that promise.
Yeah, I'll put the timer on so I actually can try and stick to that promise. Yeah, thanks so much to the organizers for asking me to show some of our data. So our lab really works on ALS fundamentally and on kind of basic molecular mechanisms, but we've done quite a bit recently on translational preclinical science, and so today I'm going to really try and touch bases on a couple of things, always around cryptic exons and its biomarkers, a new splice switching therapy for ALS that we're developing, and really a novel gene therapy platform that we're also developing for ALS and I think could also be valid for IBM. So, given the audience, I don't even have placeholder slides for IBM and ALS. I assume you've all heard of the two diseases, but I will be introducing really briefly the key protein for the whole talk, which is TDP-43. And so TDP-43 came on the scene to, let's say, the neurology world in 2006, when these two parallel papers from UPenn and a paper from Tokyo described it as being the main protein aggregated in ALS. And so you can really see, I don't have a pointer, but the dark ones are normal neurons within an ALS cortex. And so TDP is all in the nucleus, concentrated. And then around, you can see some other cells where it's actually depleted from the nucleus and it's in the aggregates. And that really happens basically in all of ALS cases. Take away some defined rare genetic forms, FUS and SOD. And it also happens in other brain diseases, in FTD and Alzheimer's, half of them. And, of course, of interest to this audience, it's basically invariably present in IBM as well. And it's present in these, rare but really interesting diseases called the multisystem proteinopathy, called them IBM PFD, basically VCP mutations and some other HNRMP mutations where families get either or both diseases, so FTD, ALS, IBM, and also Paget's. So TDP does a whole bunch of things, but basically it binds RNA. That's the key thing for this talk. And it's involved in many processes of RNA maturation. But for the sake of today, it's the fact that it actually binds to introns in around 30% of our genes. And it apparently does nothing there. No action is really going on. Normal splicing is happening there. But what Phil Wong at Hopkins found in 2015 is that when you take it out, when TDP is not there anymore, some of these sequences, not in all of these 30% of our genes, but in a number of them, some sequences get de-repressed and included in the RNA, and we call these cryptic exons. And typically, because they're not conserved sequences, they happen to either be out of frame or contain stop codons. So they really typically lead to RNA degradation and no protein. And this is how they look on an RNA-seq trace. You can see on top it's a normal cell, on the bottom from Phil Wong's paper a knockout, and you can see there's an extra with the green arrow kind of hump, which is the cryptic exon on the RNA-seq trace. Why are we so interested in them? They are really beautiful events for clinical translation because they're on-off events, right? So on top you have the scenario in which you have an alternative splicing event in disease cells among normal cells. And that can be really relevant for pathogenesis, but it's not tractable. While cryptics just happen in the disease cells. And so, of course, that's really appealing for biomarkers for their detectability. And also it's appealing for, if they have any relevance to disease, to target them, because it's easy to target something you just want to get rid of and not something that you have to carefully go modulate like an alternative splicing event. So I hope, at the end of the talk, to actually convince you that they can be detectable, so they are good valid biomarkers and they are good therapeutic targets as well. So after the 2015 finding, they were considered a fun event in the ALS world, but not really a relevant event. Then in 2019, there were 2 back-to-back papers that identified one such event. It's in pink up there in a gene called STAFMIN2, and which seemed to be important for axons. And in our lab, we were really struck when we started to look at this event across thousands of brains. And RNA sequencing from brain is pretty dirty and messy, but we were really struck by the fact that in the cerebellum, where there is no action really going on in ALS, there was nothing, it never detected. And in the cord and in the cortex, you could detect these events just in the brains that had TDP pathology. So it's extremely specific. So this really, thought, well, this has a great potential as a biomarker, but, detecting RNA as a biomarker is a bit harder. And so we set off on this endeavor along with Len Petroselli at Mayo and Michael Ward at NIH to try and identify ones that actually can be translated into protein. And so what we did is, bioinformatically, we predicted ones that were not out of frame and that, by chance didn't have stop codons. And then we, defined, like in that red arrow there, we defined their predicted protein sequence, their predicted trips and digests, and we said, well, can we actually detect these in mass spec in iPS neurons? And indeed we could for at least 12 of them. We found 65 peptides, cryptic peptides mapping to 12 genes, and which was really quite interesting. And this is always in iPSC neurons, and you can actually detect them by blot as well. You can see one such event in a gene called HDGFL2. That's the protein. You can see going from left to right, there's an increasing loss of TDP, and there's an extra band appearing, which has the cryptic peptide. So that's great, and Len Petroselli went off to actually develop an antibody specific for the cryptic peptide, and he showed that in brains, this is not like serum or plasma, it's really specific in detecting FTD with TDP path versus FTD that has just tau pathology, or Alzheimer's with TDP path versus controls, or Alzheimer's without TDP pathology. And Phil Wong, who independently identified this event, actually has shown with another antibody specific that he developed that actually in CSF, it can also distinguish ALS from controls. And I think it's you can see the CSF data, it's great. It's a Nature Medicine paper from this year. I think it's not really there yet as, a reliable assay, but it's a really good proof of principle, and I'm sure the assay will get better. And so, in addition to the classic cryptic exon, RNA loss, protein loss, I think we can now say that actually it can give rise to novel proteins. And what happens in IBM? Well, the cryptic exons happen in IBM. So on the left, you have data from a paper from Tom Lloyd, and you can see many RNA-seq traces, and all those arrows, you can see these humps that happen every 2 traces. And so the traces where there is no hump are controls or non-IBM muscles, and the cryptic exons are specifically detected in cryptic muscles. And on the right, you can see on the, how actually on the right, which are IBM muscles that we sequenced, you can actually detect a burden of cryptic exons very, very significantly different from controls. But what about the peptides? Well, when we took Len's antibody and applied it to muscle, this is all in a poster from Matteo that you may have seen yesterday, we can actually see that on the right, IBM, you can see some fibers with P62 inclusions, and you can see that they stain on the bottom row with HDGFL2 as well, so showing that cryptic peptides are present in IBM. And so this really raises the question, because then Matteo was looking at these and he was seeing that, you know, on the ones on the right that have a big load of cryptic exons, he was actually seeing both on RNA-seq and on proteomics that all the immune kind of pathways were correlating with the degree of cryptic peptide burden, right? So the more cryptic peptides, the more antigen presentation and the more T cells you get in those muscles. And so the question was pretty obvious, which is kind of what happens a lot in cancer. You have a novel peptide. Is the body, our T cells, mounting a response against that? And so this was work that was done in Jenny Jiang's work at UPenn. So we're working with it because Jenny developed this really, really cool assay to test specific T cell reaction on kind of a medium throughput. She can test hundreds of novel peptides at the same time. And so there's 3 FACS traces on the left, and you can see you have to focus on the x-axis. And you can see the one on the right is a control. There's not many cells there. But in IBM and in ALS, you can actually detect many cells that are responding to some of these cryptic peptides. And when you go and look at them, you actually see that they are mostly clonally expanded. So, of course, there will be some naive cells that respond to these peptides. We all have them. But in ALS and IBM, you see that they are actually expanded. And we went on to show that for 2 of these, HDGFL2 and EGLOM5, actually there are T cells in IBM and ALS that respond to them. So that's really interesting, and so the first conclusions, which are the biomarker part, is that TDP cryptic exons are specific for the TDP path, and they can give rise to novel peptides. And these really can be detected in biofluids, so really promising biomarker strategy for ALS and IBM, and also T cells mount a response. And so, of course, we're already seeing evidence that this response is toxic, but I think it'll be a further step to really show that it does play a role in the pathogenesis, but it's really a pretty striking finding. So moving on to the fact that to the therapeutics, right? So this volcano plot has many dots, and that's the whole point of it, just to show you that there's many cryptic exons, all those red dots. And so the point is, well, do they play a role? Do they play a role in their togetherness, or actually are there single ones that actually have a role in disease? We don't know that. But a few years ago, we were really our attention was drawn to one such event in a gene called UNC13A. And you can again see how beautifully specific it is on the top in iPSC lines. You just get it when you lose TDP on the bottom. And the exact same striking specificity is also present when you sequence neurons from a patient brain. You can see on the top trace, a neuron with path, it has it, and from the same patient, a normal neuron doesn't. So it's really specific. And this is of the first category, no cryptic peptides here. It leads to a loss of UNC13A. You can see a blot down here. There's no TDP, and actually this causes an entire loss of UNC13A. Why was our attention drawn to this one? Well, because it's the second strongest signal in GWAS for ALS, right? The first is C9orf, which is the mutation causing ALS. The second is UNC13A. And what is really striking is that amongst the 5 SNPs that drive the GWAS signal, 2 are in the intron, and actually 1 is dead in the middle of that cryptic exon. And so I'm going to really summarize here, but basically what happens is if you have the healthy alleles, so the non-risk allele, you still get the cryptic exon. But if you have the risk alleles, you get more of it, okay? And this is valid in cells and in patients. So if you have 1 or 2, this is brain data, risk alleles, you get increasing amount of this cryptic exon. And the model is that in health, TDP is there, and it just, regardless of what SNPs you have, you don't get the cryptic exon. And in disease, regardless of what SNPs you have, you do get the cryptic exon. But the difference between risk and healthy allele is the fact that this phenomenon occurs a bit more rapidly if you have the risk allele. And this small change in the dynamic of the cryptic exon really links to faster slow progression in ALS. And so, of course, the question is, well, what happens if we stop the cryptic exon? And I think one could say, well, at least we'd go from that fast and to that low progression, and who knows, maybe hopefully a bit more. And so there was still, of course, some work to do to try and develop a therapeutics, and actually, we haven't even said what UNC13A does. It's a crucial synaptic protein, so it's essential to release glutamate and acetylcholine. And so if you lose it, you don't get these spikes, which are release of synaptic vesicles, called minis, miniature postsynaptic currents. And when you lose it in iPSC cells, you replicate the data that's in mouse. You go from many spikes to no spikes. What's really appealing, when you lose TDP, you get the same thing, from many spikes to low spikes. But that's a bit of a correlation. When you lose TDP, you get all those red dots. Many things are happening. Is UNC really relevant for this? So what we did is we genetically took away the cryptic exon and said, what happens then? You get all those other changes that you get with TDP path, but you don't get one single one. And indeed, just rescuing this single event, rescues the synaptic release and transmission. So that was really exciting. We thought, well, we're not going to go and modify the genome of patients, but we may want to use ASOs. So we develop ASOs that rescue, this is the normal splicing. ASOs basically bring it back to normal. They rescue the protein, and indeed, they also rescue the spikes. So from little spikes, you go back to many, which means your synapses start working again. So that's really exciting, and so the conclusions to this part are the fact that the risk alleles are caused by this cryptic exon, that TDP induces synaptic dysfunction, and that by rescuing this UNC13A, you actually rescue this function, and you can do it also with ASOs. So we're now at the stage of developing this with actually some funding in a new company called Trace. But in the last part, all right, so that's the ASO part, and the last part is actually what we're really excited about also is this novel gene therapy platform in which, now forget how bad cryptic exons are, but we're now thinking, can we actually use this phenomenon to our own advantage? And the premise here is the following. In a dish, this is the representation of an ALS cell. You can actually rescue it with many, many different ways. And there's just 4 high-profile examples of proposed therapeutics. The issue is that, of course, in a brain, the majority, 90%, 99% of neurons are normal. So the ALS ones, the one with TDP path, are just a minority. And so if you go in and give a gene therapy that even is limited to neurons and hit all cells, what you may end up doing is actually rescuing the pathology in the disease one. But the sustained expression, even if it's a benign thing you're expressing, we know even expressing SMN is toxic long-term, you can actually end up causing damage to other neurons. And so what we think would be ideal in ALS is to have something that you give, is present in all neurons, but it just turns on when a neuron is sick, and actually, if it does the job, it then switches off, right? So you eliminate all the toxicity. And so this is what I've been banging around, that happens in patients, right? So in normal, TDP inhibits, and you get protein, and then you get the cryptic exon, and you lose protein. We thought, well, can we develop an AAV therapy that actually does the opposite? Can we put a cryptic exon in the therapeutics such that in a normal cell with TDP, it's not going to produce any protein, and only when TDP is lost is the therapeutics going to be produced. So we started to exemplify that by applying it to red fluorophores. If you apply a classic cDNA, you're going to get red in cells with TDP or without. But what if we stick a cryptic exon in it? Well, we would expect that in a normal cell, which is lacking an exon, well, that's going to be a nonsense RNA and no red, and we're going to get red just when we lose TDP. And so Oscar Wilkins in the lab developed a really clever way to do basically in silico directed evolution using Splice AI, and to design cryptic exons in whatever sequence you basically want. And so it works. It works in cells. So a constitutive red is present always. Our red with a cryptic exon, 2 different constructs, is red just where the pluses are, which means where TDP is lost. So it works in cells, and actually it works even in mice. You put this thing in an AAV, you express it in mice. On the left, normal mice, not much red, lots of big yellow TDP in the motor neurons. On the right, instead, you have a mouse that lacks TDP just in motor neurons, and you can see all the red lighting up in those cells. So it can activate specifically also in vivo. And of course, we're not in the business of giving red to patients. We'd like to give therapies, of course. So one could put whatever you want there, but we started by actually trying to apply a very clever construct that was developed by Phil Wong. So, you know, you lose TDP in ALS. So he said, well, why don't we build something that binds to the same RNAs as TDP, but does not aggregate, right? It has a different C terminal. And so we said, well, that's great, but why don't we put this gating in it so that it just, you know, turns on when needed? And so it works, meaning it turns on the splicing just where you lose TDP, and you can see here a blot. This is the chimeric protein. You get none in normal cells. You just get it when you lose TDP. And this provides a real advantage to expressing the full one, because if you express the full one and you put, you know, these cells together, the ones that express the full one actually fall out. They divide less. So it is toxic. And so, you know, by instead having this gated one, it works exactly like normal cells, so no toxicity. And does it rescue splicing? Well, you know, I've banged on about UNC13A. It rescues UNC13A splicing. This is a normal cell, and these are cells treated with this chimeric protein. It goes back not entirely to normal, but, you know, pretty much. And the beauty compared to ASOs, of course, is that it doesn't just rescue UNC13A, it rescues other ones. So here is an example of another classic cryptic, fully rescued. And here's an example of one which is only partially rescued. So of course it's not perfect, you still need to possibly make better chimeric proteins, but generally you rescue, you know, all of those dots in that volcano plot and not just one. And so that will be the vision, right? You give an AAV, possibly even to a pre-symptomatic patient that carries a very pathogenic mutation. It just stays there, it does nothing, it just activates when needed, and that's when it, you know, you reduce the toxicity and you get really early action in these neurons. And so I hope to have covered the fact that cryptic exons, we find them really exciting events for biomarker development, for new therapies, and actually for developing new gene therapy platforms. And this is the work done by a whole bunch of people in the lab and many collaborators for the IBM parts, you know, all the serum and the biopsies were done in Queen Square by Pedro's and Mike's clinic, and collaborators in Padua really contributed for the ALS PBMCs. And up there are most of the funders, and thank you for listening. That was 20 minutes.
First question. Really beautiful talk. Thank you for that.
Thanks, Pietro. It's a brilliant talk. How would you work out how you determine if the T-cell clonally expanded response is pathological and is relevant to the disease? That's the kind of important question, is it, as opposed to other consequences of the cryptic splicing?
Yeah, so I didn't show that today. That there is some data in Matteo's poster. We now show, and for technical limitations of HLA compatibility, the data we have now is in astrocytes. So we show that if we put astrocytes that lose TDP and you incubate them specifically with these T cells, these T cells really, you know, they kill them. So that's a, you know, initial sign that they can work. Well, you know, I think it's going to be tricky to model this in vivo because mice don't have the same cryptic exons, and there's a whole range of hurdles to do this in vivo. So it's not going to be easy to do. But I think more characterization in vivo in IBM by actually characterizing with spatial transcriptomics exactly where these T cells are, not the fact that they just exist, will at least bring us a step closer. But it's, to really nail that question is going to be pretty hard. Maybe trials will actually tell us, but that's yeah.
Thank you, that was a fantastic talk. I noticed in the peptides that you have that are expressed, there's some that look like agrin, I think was one, more neuromuscular, and some perhaps more central. And I wondered if there's any evidence that it correlated to the phenotype, whether it's predominantly lower or upper motor neuron.
Yeah, so your question is, well, so those we detect in iPSCs, right? So we don't still have data that, you know, that would be great to have a whole panel be able to detect not just one, but many in a plasma and do what you're basically proposing, saying, oh, is this case having more lower or upper? We've done a lot of work till now in iPSCs, modeling which cryptics are cell-specific for muscle, lower motor neurons, upper astrocytes, but we're still at that in vitro phase. I think it'll be a while before we're able to really detect all of them, if ever that will happen in plasma, and actually do what you're proposing, which is great, but I don't think we have the tools yet.
Fantastic talk. So from what you presented, it looks like the cryptic exons and cryptic proteins might be toxic, and it's clear that there's genetic driven events. But have you identified any further environmental or other factors that affects the expression of those cryptic exons and proteins?
Well, so they are TDP dependent. So I think that's the question that the whole community is after. What drives TDP pathology? And unfortunately, I don't have, but I think nobody really has a great answer for that yet. I mean, there's lots of speculations about, combinations of stressing and aging that kind of disrupt the cycling of TDP in its various, liquid separated phases, aggregates, etc. But it's all downstream to that event, which I think the whole community is working on, but I'm not sure we have great answers for that yet. Even how mutations cause it is really still totally unclear. Even mutations in TDP itself.
Great, thank you so much for your talk. So for our next speaker, I'm really excited to introduce Dr. Carissa Gable, who's going to give us an overview about the advances in the workup and management of immune-mediated peripheral neuropathies.
Thanks, everyone. So I'm going to attempt to give some context to a couple immune-mediated neuropathies, try to focus a little bit in 20 minutes. So CIDP, I'll focus a little more on GBS and just give a little context to the evolution of diagnosis and management, and then the more recent updates, and then some exciting treatment options. So as a review, as you know, this is a rare disorder. The diagnosis is really this combination of clinical and electrodiagnostic, in addition to laboratory features that would exclude other mimics. And the 2021 EA and PNS guidelines are really recommended, not for research guidelines, but for everyday use in clinic in order to help at least try to improve the accuracy of diagnosis. And so, 60-70% of patients have typical CIDP, which is the progressive relapsing type, with symmetric proximal and distal weakness of the upper and lower extremities. There's sensory involvement, at least 2 limbs. And of course, we have our variants, which make up the rest of the percentages with distal, multifocal, focal, motor, sensory. So these guidelines are the 2021 consensus update, and so afterwards there was a review written, a couple different ones actually, looking at the specificity, sensitivity comparing to the 2010 guidelines. And so the focus of these was really, one of the main goals was to try to improve the accuracy of diagnosis, in particular for the variants, which used to be called atypical CIDP. And so that was kind of one of the goals of this, and I'll talk about a little bit about how they kind of went about doing that, but essentially kind of had to give a little bit away with sensitivity in order to increase the specificity of the diagnosis. But it's really not that bad. If the extended nerve conduction studies refer to doing at least 4 motor sensory nerves in order to kind of have this acceptable sensitivity and specificity for diagnosis. So just as a review, for the typical kind, you really need to have this symmetric proximal and distal weakness, and then also reduced reflexes or areflexia. And the evolution time frame is very important. It really needs to be over that 2-month time frame. And then secondarily, the electrophysiologic features with the peripheral nerve demyelination meeting those guideline criteria. Secondarily, if you then at that point you've got CIDP. If it's in the possible CIDP category, you then go on to do the supportive testing with spinal fluid. Ultrasound is a new addition to the guidelines. Histology is rarely used, but we still do that sometimes on occasion. And of course, keeping in mind that clinical improvement, while somewhat nebulous in its definition, is also considered supportive data for possible CIDP. So just pictures kind of help visualize. We have the distal variant, upper extremity predominant, Lewis-Sumner syndrome with the asymmetric variant, pure motor and pure sensory. I find this kind of an interesting study from the Italian group. So they have such a large database of registry of patients. And so just intriguing to think about the pathophysiology and underlying immunology driving this shift from people who have a short duration of disease, and then similar to, like, I guess, ocular myasthenia, sometimes generalizing, sometimes not, and the time frame in which that happens. And so you have over this 8-year duration, a shift from the variants to this typical phenotype. So keeping that in mind when you're seeing these patients. And just a little bit about, why the guidelines exist, what the purpose of these are, and there's been so many different iterations over the many, many years. And because there's still, somewhere around 47% misdiagnosis rate, a lot of it is like underutilization of kind of criteria and guidelines, but then you kind of look at like what is being misdiagnosed and what is it actually instead of CIDP. And so these are kind of just like a highlight of what that tends to be. Just keeping in mind that pain is not that prominent a feature, so if you see that, you might want to think about something else. Axonal link-dependent neuropathies also frequently get misdiagnosed as CIDP because of interpretation of the electrodiagnostic data. And that leads to this, which is really, sometimes you think maybe it's just the data quality or the acquisition, but this study actually looked into, it ends up being more about data interpretation as an issue, and sort of overcalling that degree of axon loss that occurs that leads to mild conduction velocity slowing or even conduction block at compressible sites. So I'll just summarize by saying with diagnosis, it used to be in the prior criteria definite, probable, or possible categories, and that collapsed into its CIDP or possible CIDP. And so if you meet the phenotypic criteria, you meet the electrodiagnostic criteria, you're kind of done. You start treatment and kind of move along and see about response to treatment. I always like to reassess and kind of make sure at every visit, is the response adequate? Are they at a plateau? When can we taper? And that sort of thing. But, you're kind of there. But if it is not met, or if you have a question, then you're in the possible category, then you need to go forward with, extra testing. And so that's where some of the guideline updates here, just looking at the CSF protein elevations, there's been some research into this as well, looking at the 45 milligram per deciliter cutoff as the typical upper limit of normal is a bit on the low side because, and so we found that actually increasing that even more with age, and also a consideration for other conditions that can raise elevated protein, just cautionary recommendation with mild or moderate protein elevation, it might lead you down the wrong path, so you want to keep that in mind. Ultrasound criteria was added to the new guidelines for the workup. And so this looks at the cross-sectional area of the median nerve or up into the brachial plexus. And so in addition, if you have 2 sites that have this degree of cross-sectional area increase, then it would support the diagnosis. In addition to, of course, I don't mention MRI because that's kind of a known entity, but if you do imaging with MRI and see enhancement or nerve root enlargement, that's also supportive as well. And then this was also added. So the sensory nerve conductions, so this was added, of course, keeping in mind temperature is very important here if you're considering velocities of sensory nerve conductions, but this was added in order to help improve the kind of more atypical or the variance. So lastly, I'll go into this treatment response as supportive diagnosis, in support of the diagnosis. And so the treatment response is very important because that's how we make diagnostic conclusions, that's how we make long-term treatment decisions, and then it also is part of the guidelines as an objective clinical improvement, is supportive. And so, but evaluating that is actually difficult. As we know, there's no biomarker at this point for serologic diagnosis or management. There's not even really a standard definition of what a responder is, and there's a lot of heterogeneity amongst the variants. And so I like to recommend doing these kind of assessments, and this is from the NMSG consensus meeting to talk about other potential objective outcome measures in addition to the clinical exam. So you can use, Martin Vigorometer or the Jimar hand grip for strength and RODS for disability. And so I refer to this when I look at assessing these with my patients. Of course, NCAT is used as a primary outcome measure in clinical trials typically, and these are all the other secondary outcome measures that are typically used. And I do these in clinic, they're very easy to do. Patients like to see them. There's actually apps in development for doing home assessments so patients can follow and collect daily data and kind of keep an eye on things. So, because as they trend all generally in the same direction with improvement. If you see that trend or plateau, it can help you kind of make a decision on treatment and how to manage or taper or to increase treatment as the case may be. So that's kind of the update and the workup of CIDP at this point. And then I just want to transition a little bit to the treatment landscape, which is evolving and really exciting. So I think I'll just say, with the pathophysiology of CIDP, we know it's multifactorial. There's innate and adaptive immune systems that are involved. So there's macrophage demyelination that leads to complement deposition, and that's been a proof of concept in a number of different in vitro studies. And then we know that with the B cells producing some kind of autoantibodies are also involved in addition to T cell mediated disease as well. And I think in the last 10 years, the kind of interesting discovery of the subset of nodopathies and paranodopathies was technically in the guidelines are not considered CIDP, but of course they just have a different target. It's really more of a syndrome, actually, probably. And so this is more like IgG4 mediated disease and responds better to B cell depletion with rituximab, similarly to like musk myasthenia. And so I think, so this syndrome, just a little snippet here to kind of summarize some of the clinical features that are somewhat different. Oftentimes these patients are younger and more tremor. They can have nephrotic syndrome in some of the cases. And generally speaking, they could have no or a partial response to IVIG or steroids or plasma exchange, but really respond. And sometimes I have many patients in medication-free remission. Well, not many, because it's only 10% of like CIDP, but a fair number that are in medication-free remission after rituximab and a couple rounds of dosing. So I think just transitioning to treatment, I'm going to kind of focus on what the guidelines currently say. There definitely in the next couple of years are going to be an interim update on just treatment consensus guidelines because of the evolution of all the different therapies that the ones that are here now and also likely will be here in the near future. And so I'll just focus on what's sort of approved at this moment in time. But steroids, IVIG, we know the pluses and minuses of those. We now have monthly sub-Q injections, which are a great option for patients as far as frequency of administration and also weekly subcutaneous. There's also things in development for high percentages of sub-Q IG, so you have less volume and it's more tolerable. I'll highlight the steroids area here just to say that the OPTIC study, I don't know how many of you are familiar with that. There was an open label study in 2019. There was a small study that looked at treatment-naive patients and the combination of high-dose IV methylprednisolone and IVIG every 3 weeks for 18 weeks, and with the idea of inducing remission, because in some of the trends of the literature amongst CIDP and comparing steroids and IVIG, there was this trend of steroids might have a chance of putting people into more long-term remission, and so that's why this study was done out of the Netherlands. And so the initial kind of prospective, kind of open label study was kind of interesting, and it showed 60% of patients at 1 year after this 18 weeks of treatment every 3 weeks with this combination therapy actually did not require redosing, and they were sort of in remission. So then they went on to do a randomized control trial. The data is not published yet, and it was actually unfortunately stopped due to 4 thromboembolic events in the combination arm. So they're kind of trying to sort that out, but it was kind of interesting trends to mention. So I'll say covered that. And then plasma exchange, of course, is considered one of the first-line therapies that's useful in certain situations where patients might need to quickly be turned around, but not a good maintenance therapy due to all the reasons you probably are well aware of. And then, of course, we have the oral therapies. There have been smaller trials. We still use some of these. The guidelines, actually, there's like just observational data for this. And I think rituximab, actually, this was just published in August. There was a prospective study of 17 patients, and this was from the Italian group as well, that showed that there was a pretty remarkable improvement at 6 months and a year with continued CD19 cell depletion even at a year. So just promoting that can sometimes work, probably for a subset of patients. And so the practice point guidelines from this point recommend kind of considering these as steroid-sparing agents. And then we come to this, which is now just recently FDA approved, the efgartigimod by this mechanism of action in end of June. And so then trying to figure out how to incorporate all of that into the algorithm of treatment is going to be interesting, to say the least, and kind of nice to have options for patients and how to approach that. So I spent way too much time probably making this in 2020 when I wrote this review with Jeff Guptill. Now AI could probably do it in 2 minutes, but like I was moving all the little fragments around. And so I think I just want to summarize that the top line here is just the IgG recycling mechanism, where IgGs bind to the Fc receptor, and then they get recycled, and anything that's immunoglobulin that's not bound gets got shifted to lysosomal degradation. And that's the idea behind the mechanism of the anti-FcRn antagonists, is that they block IgG binding to the receptor so that more immunoglobulin is shifted to lysosomal degradation. So the HERE study, just really briefly, was what led to the FDA approval of this medication for CIDP. So it was a very large study. It was kind of a novel trial design. They actually looked at patients who were treatment naive and standard of care treatment withdrawn. So people had to get worse. Then they got into stage A. Everyone got put on drug as an open label portion. And then when they got better again, they went into stage B for a randomized placebo portion. And now there's an open label study ongoing. And so the results of this are that in stage A, in the open label portion, about 66.5% responded and 61% lower risk of relapse in stage B. And kind of outcome measures, NCAT was the primary outcome measure with the others as secondary. So site reactions, sometimes common, I haven't seen that yet in my patients, and then increased risk of URIs are also side effects. And I would say, I can't go into all the other mechanisms of options for future options for treatment. I'll just say there's some complement inhibition trials ongoing, and then also other anti-FcRn inhibitors and other mechanisms of targets. So in conclusion, we have this kind of general kind of framework, but of course we know that the treatments available have been available, are rather effective, but also have their limitations, and so there's a significant amount of unmet need that's led to a lot of development in this area, which is very exciting. So remains to be seen how all that's going to take place, but I think I always think about on my patient individual basis and what's best for them as far as risk-benefit profile and the other comorbidities that they might have before choosing an option for patients. Really quickly, because there's been a couple of developments that are really exciting too for this. So worldwide, GBS affects 100,000 people per year, and the incidence is between 50 to 70. Males are affected more. We're kind of familiar with the symptoms, but I think this is kind of the spectrum of variants that you can see for GBS. Of course, it's a wide variety. Every once in a while, we'll see a pharyngeal cervical brachial variant a couple times a year. I think the main two consensus statements that I'd recommend are these. This one from 2019 for the 10 steps is really, really effective and useful. And then the recent consensus guidelines came out in 2023 that go through a lot of detail. And so I won't read through all the algorithms. These are taken from the guidelines, but I just want to highlight a couple points. And one of which is that this kind of just helps you with the algorithm of decision making and making sure you're not missing anything, but also like considering the patients who have 3 or more treatment-related fluctuations. You might want to consider either acute onset CIDP or pan-neurofascian nodopathies that respond better to rituximab as well. And then the assessment and monitoring of GBS using the EGRIS scores to kind of stratify risk is very important. And I'll highlight the SID-GBS study, which is a double-blind randomized placebo-controlled trial. First I'll say IVIG or Plex in treatment, just not IVIG then Plex, because that's just like a terrible idea, but people still do it. And the SID-GBS study is basically a really interesting poor prognosis patients who were enrolled in the trial, and then they were either all given standard of care and then randomized to whether they got a second round of IVIG versus placebo. And what they found was actually a double risk of patients. 4 patients died. There were increased thromboembolic events, and it was double the risk to do that. So the recommendation is don't do that. And ultimately that's in the guidelines as well. And the bottom there with the poor prognosis, don't repeat IVIG courses. Further deterioration despite treatment, there's not any evidence for switching to immune therapy. However, if there's improvement and then worsening, that's a treatment-related fluctuation, which is different, and that needs to be treated. And lastly, I'll say, which this will be part of the industry presentation session later in more detail, but this is the first placebo-controlled pivotal study in GPS in probably 40 years. It's a C1q blocking antibody. It was done in Bangladesh. There's a single dose that was given less than 10 days of symptoms. And the lower dose, they did 2 doses. The lower dose actually was the most effective. The higher dose actually demonstrates that more is not better. It actually interfered with macrophage clearance of complement deposition that actually helps over time improve things. So the 30 milligram dose was actually the most effective. I'll just do a little reminder of where this affects. It's the classical pathway, not the lectin and alternative pathway. And this is my last slide to say that the remarkable thing about this was that it really significantly improved the trajectory of improvement, where patients would be sitting on a ventilator for 28 fewer days, be able to walk 31 days sooner than they would have able to previously independently. So it's very, very exciting. So with that, I'll say thank you.
We'll open up for questions. Thank you so much. One question I had was, what's your general approach for tracking response, just your gestalt? And do you have any ideas on like up and coming biomarkers or things that we could track in an objective way? Like that seems like one of the biggest gaps.
Yeah, I mean, that's an active area of research, really. I think what we reliably have right now are the grip strength and the kind of other outcome measures, rods, and you can use timed up and go, which we're going to validate. And then I think you can use that, NFL is frequently looked at in some of the clinical trials experimentally, but we know it reflects axon loss, but we don't, and we know that in treatment-naive patients it's high, and as treatment goes on and they improve, NFL does go down, so it's really sort of notable in treatment-naive patients, but not necessarily useful in the kind of long-term management.
Do you ever do periodic nerve conductions to track response or kind of get a baseline? I know it's a moving target, but...
Yeah, I don't, because the improvement, so the clinical improvement, so the electrodiagnostic study findings often lag behind the clinical improvement, and so I think I use the clinical improvement. If someone's worsening, then I would recheck them, yeah.
Hi, thank you for a great talk. A lot of ground you covered. Any experience with FcRn inhibitors and Guillain-Barré?
No.
Okay, thank you.
Short answer.
Great, thank you. So our last talk of the morning is Dr. Reza Sayed Sajadi, who's going to give us a talk about peripheral nerve imaging in Charcot-Marie tooth.
Oh, I can see the slides here, thank you. So, such a great honor to be here. Thank you for the invitation. I'll give actually mostly an overview of what has been done in nerve MRI, not ultrasound. Not knowing that I just said peripheral nerve imaging, there's a big component of ultrasound that I'm missing here. And also the grant that supported this work, and I will present the results of that study, which is interesting. It took a while before we could get the data, but I think it's worth looking at it. So Mario nicely summarized all the efforts that have been done in the world of CMT, including therapeutics and definitions of the diseases, mostly the focus, which has been on CMT1A and some other types. But there has been more and more emphasis in being able to do more translational studies, smaller ends, and need for showing efficacy, especially in diseases that are very slowly progressive. So most people in neuropathy world are very familiar with these studies, and in NMSG group as well, which has been part of these efforts. And as On the left side of the panel, you see some preliminary studies from effectiveness of ascorbic acid in animal model of CMT1A, and clinical trials spending millions later failed to prove that actually the treatment worked. One of the explanations was whether we used the proper tool to look at the disease, and ever since there has been multitude of studies and efforts trying to find out what is a translatable outcome measure that we can look at that would be helpful in detecting the changes or improvements in the conditions. So we'll hear from Jasper about his efforts in muscle MRI at this prolific study from his group. It showed that actually he can detect disease progression fairly reliably and in patients with CMT1A over the course of a year, with especially if you have like moderate degree of disease severity with more baseline muscle fat fraction. So I stole this from Mario with his permission, and this was one of his last slides from his presentation yesterday, and I found it very informative. And in summary, actually, you can see by the sensitivity, or what probably a surrogate way of looking at or comparing different outcome measures by looking at the SRM or standardized residual mean, is that what number you need for a clinical trial to show an effective or improvement in the course of a year with 80% of power. So a muscled calf MRI actually has been very good in the studies that we have looked at, especially if you have more moderate disease severity range. If in general you need like 100 patients with CMT to be able to detect a change, and if you look at the specific degree of muscle fat fraction, you can actually get the same thing with N of even 10. But do we need more, and how can we complement this? So the question was whether nerve imaging, which is essentially the target organ, can complement this, and why nobody has looked at it before, or they have. So we'll talk a little bit about that. Peripheral nerve imaging with MRI specifically, there are obviously clinical imaging that we look at, T1, T2. Nerves look like very small structures typically that we cannot really do much measurements about. There's been some volumetric studies, very long studies that patients have to stay in a scanner for a long time. There are mixed models that physicists use to calculate the general volume of the nerve, and diffusion imaging, which has been more attractive recently. So there are older studies looking at patients with CIDP, and they've done like long hours, like 8-hour-long study of measuring the size of the nerves and showing that actually there is significant difference between the size of the nerve in patients compared to controls, and the disease duration association with the size of the nerve. They've also looked at diffusion imaging more. So diffusion imaging is interesting because it is very sensitive if you have a smaller subject, or a small animal study. You have a sciatic nerve, you damage it, you can almost measure exact number of axons in a nerve and measure their growth in the nerve. So, and associate them exactly with the number of the density of the nerve. So they have tried to replicate that in patients with neuropathy, and they have done a nice job of looking at this again in patients with CIDP in the proximal sciatic nerve, with some association between diffusion measures and the nerve. So in CMT world, the efforts start about a decade ago, and mostly they came up with ideas about how we can do this with something that would be representing both myelin dysfunction and also axonal changes. So they introduced new measures, and they did a smaller study of looking at different types of CMT, and they found that actually there may be some association with the degree of CMT and signal change of demagnetization transfer ratio. but most studies were done by our Korean colleagues and French colleagues. The first study, they compared 18 patients with different demyelinating CMT patients and different levels of sciatic nerve proximal to distal, and they again showed that actually there is a good distinction between patients and controls. Follow-up studies, again, by our French groups, they've looked at the MTR, comparing patients with CMT1A to controls, but they've used a smaller scanner for the practicality purposes. And they've shown that actually, again, there is some difference between MTR, between patients and controls, and maybe there is some association with disease severity and the volume of the sciatic nerve, but not MTR. The same group, years later, they did another study looking at, again, patients with CMT1A, and they had 24 patients, very clean study. I don't know why, but they forgot about MTR, but they did measurements of fat fraction, and I think this was more sensitive. They showed that actually sciatic nerve proximally, there is a good association between the disease severity, the way they measured it, and they also showed some change, I don't know how significant, in the fat fraction over the course of a year. Just looking at the numbers at the sciatic nerve, this is not close to what we had from the muscle MRI numbers, and probably not that useful for clinical trials, smaller scale clinical trials. So we got interested in this because in our center, the Martino Center that we collaborate with, they had developed this technique that they can actually have a bigger magnet and make a more accurate measurement of the density of the nerves and also number of axons in animal models. This is from porcine study of looking at the optic nerve and sciatic nerve and measuring almost accurate calculation of these measures. And they have done actually studies looking at, this is the corpus callosum on the left side and the spine with that very small study, but they could show that actually they can measure again, diffusion to the degree that they can estimate the axon size and density in these things. So getting this idea, this was the proposal to NMSG that they agreed to support the study to develop something that we can actually look at the axon size and density in the patients with CMT1A. The idea was, can this complement MRI efforts in terms of looking at the disease severity and also the regenerative capacity of the nerve. So these were the original aims of this study about, like, one, compare healthy to disease, look at the association between other biomarkers, and also look at the longitudinal changes. And this was the simplistic idea of that, oh yes, we are going to develop a coil, we are going to do a phase 1, do a validity, and the phase 2 is responsiveness. But not everything goes as planned. So we got the first scan, and this is like I think this is the only scan that will ever exist from this, because the coil broke. The postdoc took part of it home, never brought it back. And then physics department decided that Excalibur is not safe for extracranial studies. So we said, okay, what are we supposed to do? At the time, our hospital had got a 70 MRI, and we said, okay, let's try to revive this. So I don't know how clear is there in this screen, but it is supposed to be looking at those soccer team signs on the right side. You can see the Russia and Croatia. So 70 is supposed to do that. It is supposed to give you a better resolution of the lesions that you have with the T1 and T2. But you are going to lose some other information that you get from 70 unless you do some special type of calculative things that we couldn't at the time. And that is diffusion. So there was a trade because we were all investing in looking at the diffusion to be a better marker. Now we are looking at something completely different. But we had enough support, and also Siemens, that was our scanner supporter, was interested in sort of helping us look into this a little bit more. We went back, and actually our colleagues in Stanford had looked at distal tibial nerve with a very good actually resolution or anatomic resolution of the fascicles. We said, okay, we can get their protocol and look at the proximal sciatic nerve, the ideas that we had. Let's see what we can find. They plan to get 10 patients, 10 controls, and bring all of them back in a year, around the time of COVID. So we got 6 patients, and we were rationed by the shortage of national shortage of, we used to say IVIG now, national shortage of helium. And we prioritized to bring 6 patients first, and then found 6 age, gender, weight matched patients, and 4 of the patients we could bring back for follow-up. It took longer than what we had anticipated. So these were the first images that we got. So we first wanted to see if actually 7T was better than 3T. Was it feasible to do this? And you can see in the bottom row that you can see that this is a healthy subject, the proximal sciatic nerve, both fascicles of, I think this, so tibial and peroneal or fibular, whichever you like to call, components of the sciatic nerve. You see individual fascicles compared to 3T. I have to admit that our 3T was not bad at that time. And also you can see a better resolution of T2 relaxation. So we got excited, and this is the first picture that we got from sciatic nerve of a patient with CMT1A. So I put this in loop. You can see both tibial and peroneal fascicles, individual fascicles, and a vessel that comes and goes through them very clearly. So we could also, unfortunately, this video didn't play this morning, but we could go very beautiful pictures of T2, or maybe it does, T2 signal. And we could also do like reconstruction of the whole proximal sciatic nerve, where it diverges into the tibial and fibular or peroneal divisions. So it was interesting to compare them with the healthy controls. And this is one patient with age-matched control. There are a lot of problems with this graph, but I'm going to show you what is not a problem, and what is exciting is that we see actually a bigger nerve size. Not a big surprise. We know that chronic remyelination leads to enlarged nerves. But you can also see that we can do a good job of measuring the diffusion in this particular patient. Unfortunately, this was not something that we could do in everybody. I mean, pictures were not this clear in most patients. But T2 was very better in terms of, and more consistently good quality in all studies. We also did some experimental measurements of fat fraction and some other measures. So the last one, the big one, is the T2 signal change, which is significantly different. So we did some basic comparisons, and I couldn't do a better job in terms of putting these together. You see that the size of the nerve is obviously bigger in patients with CMT1A. There is some change in ADC, but it's not significantly different. And also, fat fraction was not different between the nerves in patients. We had some ideas about whether demyelination had to do something with the fat metabolism and whether we could factor that in other analyses. But what was most consistent was that we saw that there is some difference, although not very significant, in the distribution of T2 signal between patients and controls. So each point, each dot is representing a fascicle, and the T2 value from proximal sciatic and tibial and peroneal color-coded in each of these and this was the most or prettiest picture that we could get. There was more into this, and we could do more analysis, but not with the numbers that we had in terms of the density of these T2 signals in between patients and controls. And we said, okay, maybe our N is small. What if there is an association with the disease severity? Maybe that is going to be helpful. And the patient in the top row is a patient who is a control. The second row is a patient with a milder CMT, with a CMT-ES score of 8. And the patient in the bottom has a CMT-ES score of 12, which is, again, mild to moderate, if we agree on what is when you pass that range. And in the diffusion measures, you see some natural change over time. With the T2, maybe you see something that is telling you that maybe there is a difference, but the size was not as helpful in terms of determining disease severity. So we did some measurements about this and calculated that actually different measures, but these were more helpful ones, is that we didn't see a significant correlation between disease severity, and again, a very small sample size, and area of the nerve, something that we think about, that chronic reinnervation can cause larger nerves, but we didn't see that in our patients. And with also diffusion measures, we didn't see much actually difference. The only single patient had lower diffusion, was the mildest patient, but that's not something that you'd see in the rest of it. However, with the most reliable measure that we had with the T2, we saw actually that patients with higher disease severity had higher T2 signal. And that is concordant with what we see in traumatic neuropathies and other things that have been previously looked at. So this was the more interesting part to me. So only 4 patients came back, but was it possible to learn something from this, given that how many fascicles we have and how many sections we've got from the patients? So this is the very same patient. You would see that anatomically it would be difficult to align the patient the same way every time they come. And you see the picture looks different. These are identical sections from the same nerve that we have marked. But interestingly enough, we could see a significant difference from baseline to follow-up in 4 patients. Again, I would argue or criticize that maybe we cannot really see the difference or reliably say that there's a difference because we don't have a control to say this. And the sample size is not big, and this group of patients do not represent the wide variety that we see with patients with CMT. This is milder form of milder disease severity. But still, I think numbers were promising because we could see a relatively good change over the course of a year to 10% in the perineal nerve, which is remarkable with a relatively acceptable standard deviation. So this gave us some hope that maybe it is worth looking at a little bit more deep. So it came up that this gives us some opportunities. We need more patients, but we can do better visualization of the total nerve, measure individual fascicles, opportunities to look at different metrics there, more reliable signal, maybe more sensitive or responsive biomarker for milder disease compared to what we have from the MRI imaging. What also came with the challenges that validity is a big issue because obviously it's a very small study, but it can be expanded. Feasibility, we went through 2 phases of losing national shortage of helium gas. The scanner broke, the coil was missing, the postdoc forgot about something, and generalizability. Not every center has a 7T MRI. If you're going to run a study, how many people are going to do this thing? How are you going to train people to do the same thing? Is it worth doing it? Each Tesla, I read, that is equivalent to $1 million. So a 7 Tesla MRI is going to be $7 million versus a $3 million. And I like to put one of my favorite slides from late great Ted Burns about, this is in a different context, about outcome measures. But is it always worth going through the hassle if you're going to get the answer with something simpler? So, and I end with that.
Questions?
Jasper. Be kind to me.
Go ahead, Arch.
Hi, that was really great talk. I have a question. Since you're doing MRI, I know it's on the whole nerve in the lower extremity, have you think to normalize the values to something like, I don't know, to the cross-section of the whole limb or the cross-section of thigh, leg, I don't know, the muscles there? Yeah.
It's a good question, and I don't have a good answer for you, but they do some normalization with the muscles. We've also looked at the muscle and bone and all of those things too. But there are good physics question that how to make sure that actually your measures are comparable to each other.
Yeah, great talk, thank you. Very challenging, imaging nerves, and quantitatively not something I want to try to do. I much prefer muscle. I just wondered if you had any theories or speculation on the cause of the increased T2 within the nerves?
I was expecting that question, and again, I don't have an answer for you because I tried to ask, again, physicists about this. They said that, oh, the harder tissue has higher T, lower time for the protons to stop. It could have been easier if it was diffusion, because you would have thought that the water is going in one direction versus moving around, and that correlates with like a lower diffusion number, but I really don't have a good answer. But this has been persistently seen in, like, I think there were a couple of carpal tunnel studies that they've looked at that, but I don't know.
Thank you. I just wanted to know, did you look at any magnetic susceptibility to look at there's iron dysregulation that could also point to something going on with the nerves like we do for QSM and for some of our ALS patients in the brain?
It's a good question. No, but that's good suggestion. Yeah, thank you.
That's great, thanks. So I feel obligated to ask this question since this was a neuromuscular study group funded study. Is it lay the foundation for further work or not?
Not yet, so.
Great, let's thank our speakers from this great session.
Thank you.
Trials, lots of examples here at this meeting, and so I'm not going to talk more about this, but there are other reasons. And you guys can puzzle over who the artist is. But another, I think, is exemplified by NCI-designated cancer centers, where they're judged on the percentage of their patients that participate in clinical trials. And that's not just for margin, it's not just for academic stature, it's really patient-facing. Patients want to participate in research and clinical trials. And if you think about this from a departmental or center-based perspective, having clinical trials that represent broad disease mechanism, broad therapeutics, patients having choice, that's really important. And being mindful of which trials you participate in and thinking of it from a patient perspective. No, it's John Constable, believe it or not. So, yeah. And they keep getting stranger. All right, this one's pretty easy. If you guys can't figure this one out, I had to throw an easy one in. So I investigated initiated clinical trials. This is a subtype of the first example, and I raise it because when I first thought of these, I thought I had to be the guy who came up with the idea for the particular agent or approach being tested, and that's not the case. You just need to have colleagues or friends who have good ideas, and then you can help implement them. I'll give you an example later, but I think that's the value of being in meetings. And in fact, the idea for a clinical trial I'll show you in a moment actually came from someone else who told me to do it to other people. And this is in the style of Da Vinci. Go figure. All right, this one's hard to figure out as well. So we don't talk a lot about this, but as you're putting together a trial portfolio, always look for trials that generate margin or residuals. Many of us work in institutions where we keep a substantive part of those. If you don't, then I guess you're doing something for the greater good. But many of the trials we're most excited about either have a very thin budget or you lose money. NIH clinical trials tend not to leave a lot of money on the table. And furthermore, it's nice to get some money in hand to help support pilot projects, backfill deficits, bridge funds, junior investigators. You don't want to do trials that are not of some interest to patients, but it's always nice to have some to bring in margin. Oh, by the way, grandmother Moses. So this one, no one's going to get this one either. So the other trials that sometimes we do, I think of them as parachute trials. You don't need a clinical trial to prove that a parachute works, but sometimes you need a clinical trial to convince payers to pay for the parachute or to get a more affordable parachute in the hands of patients and physicians. Kandinsky, Wassily Kandinsky. So there's one that I think you guys will get. All right, so what else can trials tell you beyond efficacy? How might we use clinical trials? So I think one is taking advantage of an efficacy trial to learn something more about how to do clinical trials. And so I think every time you're designing a trial, think about the barriers you're facing and the challenges in designing that trial, and try to tuck things in that inform future trial design. This is Georgia O'Keeffe. And a good example of this is Topspin NN108, which was done through the NeuroNext network. We published this a year ago in JAMA. This was, I guess, an IIT that I hadn't even thought about doing, but there was an FDA meeting about neuropathy probably, 10 or 12 years ago. Some of you may remember we were called to NIH by Bob Rappaport to kind of come to the principal's office about why there hadn't been significant therapeutic development in neuropathy. And on the way in, Bob Dworkin and Arthur Vinnick were talking with me about our work in diet and exercise and metabolism, and it was Bob Dworkin who said you should do topiramate, which turned out to be a very interesting clinical trial. I won't get into the results, but we designed this trial mindfully to address problems in the field. Most importantly, the clinical meaning of biomarkers that we use all the time in clinical trials for which there's very little evidence of their utility. So we're just completing those analyses right now. We also modeled a new way of having co-primary outcome measures in neuropathy clinical trial using a structural marker and quality of life marker with a go, no-go of efficacy in one and non-inferiority in the other. And then the value of doing a trial through NeuroNext and lessons learned is you've got the whole network behind you. In the room, you've got the sponsors. NIH is in the room because these are collaborative, cooperative awards, U awards, and you've got the network executive committee. So we were able to move very decisively when things weren't going well. And this trial actually succeeded, as do many, because of Tony Amato, who had the suggestion, why don't you enroll people with diabetes? We've been trying to do a metabolic neuropathy trial for a long time, and NIH would never fund it. And so I think the network and the planning for how to design future studies were key parts of this. So trial readiness studies, this one is pretty easy. Who is this? Van Gogh, yeah. So I don't know how this is trial readiness. It's a neuromuscular trial. I learned if you put neuromuscular into Gemini, it gives you lots of muscles. So trial readiness studies, and I'll give you a couple of examples of this. These are studies that are not intended to look at therapeutic efficacy. And the first was I call this the Reese's Peanut Butter Cup study. This is the first study I ever led with Rob Singleton, which was designed as basically a clinometric study to prepare for a potentially disease-modifying drug for pre-diabetic neuropathy. And the diabetes prevention program had been published the year before. So we included a standard of care diet and exercise regimen. And this was obviously meant to be a natural history. It turned out to be an open label study, and it worked. Patients got better, both in terms of their epidermal innervation, and for those who could participate in the program, they actually had improvement in pain and other measures. So this really was meant to be trial readiness. It actually turned into something more than that. The other thing that's interesting about this was our third submission. And if we had been funded on the first two, I might not be standing here today. So every time you get grumpy reviewers, sometimes it's for the best. We're doing one now that's actually really cool. This is a Roy Freeman project. He's our contact PI. It's sensory phenotyping to enhance neuropathic pain drug development, or SPEND. And essentially what we're doing is using a simple, relatively simple bedside QST regimen to pain phenotype patients. And there's a lot of evidence now that there is differential response to particular therapies based on pain phenotype. And so we're going to assess the pain phenotype, and doing this during the UG3 phase across 5 or 6 different centers, just to prove we can do it and that we have the enrollment capacity. And then there'll be a trial that randomized patients to a crossover between pregabalin, duloxetine, and a placebo that's not intended to look at efficacy of these primarily. It's really intended to look at whether or not the pain phenotype predicts response to pregabalin or duloxetine. So another reason to do trials, I mean, all trials are about mechanism, but generally speaking, by the time you get to a clinical trial, you need to have demonstrated we have the mechanism pretty well figured out, animal data, target engagement, and all of this. But there's sometimes trials that we do primarily to understand mechanism. This is Edward Hopper. And I'm a big Hopper fan. I don't know, it's a little steampunk to me. But and an example of this is work that we did to try to understand why it is that diet and exercise-based therapies work for neuropathy. And so we designed an experiment using a capsaicin exotomy reinnervation, where you do a skin biopsy, put on capsaicin, and then do another skin biopsy demonstrating the loss of epidermal nerve fiber density, and then you can do serial skin biopsies to measure nerve regenerative capacity. And we did this in a group of patients who had metabolic syndrome, measured nerve regenerative capacity, did fairly intensive diet and exercise, and measured it again, and found that there was about a 30% increase in nerve regenerative capacity. You can see that on the right as just a percent of baseline fiber density recovered, or as a rate in B. And the rightmost image demonstrates that this really was most effective in people who were able to improve metabolism across the multiple different domains of metabolic syndrome. So it appears that diet and exercise for patients who have metabolic syndrome may be effective, in part at least, by enhancing nerve regenerative capacity. And that generates lots of questions that can be back translated into the laboratory. It turns out that when we did the same thing in patients who had gastric bypass, if you look across 1 year in A and C, you will see that there was improvement in neuropathy, there was improvement in distal leg fiber density, and a very significant improvement in individuals who had with symptom inventory, the Michigan Neuropathy Symptom Index. These, by the way, were patients who did not have overt neuropathy. And so it really seemed to have an effect, but in the middle bar, it did not change nerve regenerative capacity, which is interesting. But what it did do is it increased the percentage of GAP43 expressing axons that were in a regenerative phenotype. So there appeared to be attempts at nerve regeneration, or an increasing nerve regeneration, that were not effective by the measure we use. This slide is just meant to show GAP43. This is from a different study. This is another Edward Hopper from Gemini. So trials of novel healthcare delivery models. I think this is really important, and I don't think we get excited enough about studies like this. It's great to have exciting gene therapies, but for many of the diseases we treat, we don't have a home run therapy, and really what we need to do is figure out how the therapies we have can best be utilized. There's also the issue of dissemination and implementation. It takes 17 years for a new discovery to make it into clinical practice. So these sort of studies can be particularly impactful, and so this is really my plug for that. And I'll give you a couple of examples. One is the pain control study, a PCORI trial. Rick mentioned this morning, which was actually found this a really fun study to participate in, an adaptive trial design, which made it for us fairly easy to enroll participants across these 4 drugs. And the primary outcome was very patient-facing. If you had an effect and you didn't quit the medicine. So if you look at the second line row at the top, you'll see the number in percent that had efficacy and were able to tolerate the drug. So those numbers are pretty discouraging, yet they are of meaning, and you can see the probability in the bottom. There was a plan for a larger Beat C-SPAN study that did not ultimately get funded. Hopefully we can get that done, but this is really a care delivery grant, isn't it? Another that's going on right now that I have some bias on this, I'm one of the co-PIs, and Noah Kolb at the University of Vermont is our fearless leader. This is across 3 sites where we're studying a new care delivery model for chemotherapy-induced peripheral neuropathy, where individuals randomized to the treatment arm have remote symptom monitoring. They can use a website, a phone-based system, or an app, which I'll show you in a minute. And then anytime they log a moderate or severe symptom, they get a call from a nurse practitioner who's been trained in a very thoughtful care delivery algorithm. Those nurse practitioners are all at one institution there at the Huntsman Cancer Center. So this is a very different way of providing health care, and it's one that's easy to see implemented in other chronic conditions that we treat. And I know Mike and Noah are working on this in myasthenia now, and I think if this works, we'll be looking at it in other disorders as well. This is a picture of the app that the participants use. Prevention studies. And this you might guess this. It looks like a rustic sort of image. It says Frederick Remington. So prevention studies. We obviously are thinking a lot about that in terms of gene therapy with newborn screening, which is super exciting. We've looked at this in diabetes and have shown that if you take patients who have diabetes without neuropathy and give them a diet and exercise regimen, you can not only prevent the decline in epidermal fiber density, but you have nerve regeneration. The problem, though, is the effect size is not such that you would need an enormous number of people to actually do a clinical prevention study there. But we're actually looking at another idea in CIPN. We know these patients are going to get neuropathy, so why not look at them there? And so I have a group of colleagues at our institution who are experts in advanced glycation end products, which many of you know are really critical in diabetic neuropathy. They're also important in cancer and in cancer complications. And so we're beginning a project that's intended to develop more of a preclinical base of evidence regarding age relevance in CIPN, and doing a clinical project that's going to gather data regarding the relationship with age levels in CIP risk and CIPN severity, with the goal of doing a clinical trial. This idea never occurred to me. We thought about doing diet and exercise studies. Those are actually happening right now, but more to come hopefully on this soon. I think this is my favorite of the AI-generated art, and this is doing studies. This is the parachute study. So a study where there really isn't equipoise, but we need to do in order to provide access to therapy. Anyone want to guess this? Anyone else? It's Andy Warhol. So I have no idea. It looks like a dentist to me, but and so a good example of this is Dapper with 3,4-DAP. And I can never resist an opportunity to talk about financial toxicity and drug pricing. This is my homage to the late, great Ted Burns here. And so the Dapper study was organized in order to try and provide an affordable option for 3,4-DAP to patients. And there really wasn't any question about the efficacy of 3,4-DAP. This study was not all that much larger than other ones. It wasn't large enough to really provide a lot of safety data. It was purely for the FDA. And it was positive. You can see the effect here. Basically, patients who were admitted to the research unit and then underwent a randomized placebo withdrawal of therapy and then rescue. And so this trial did not succeed because we know what happened in terms of the price of the agent, which is still in the marketplace. But I think this is a reasonable cause for doing a clinical trial. I think I can't think of many other examples of this, but I think it's informative. So I have no idea if I'm over or not. Hopefully I'm not. But just some of the lessons in summary that I take from all of this. I think one, we didn't really talk about this, but enrollment's always harder than you think, right? And I think this is one of the values of having a network. You have to decide very quickly and decisively to address problems, and that's hard to do if you're on your own. It's a lot easier to do if you have Tony Amato and Merritt in the room telling you to do it, with the sponsor in the room agreeing to do it. So I think it's really important to recognize that, at least for someone like me, I need a team, and network trials works. MSG works, NeuroNext works, and if you haven't done trials with that support, give it a try with MSG or one of the NIH networks. I think always think about how you can improve trial design as you're designing a trial. Never take advantage, always take advantage of that. That way a negative trial still is informative. And I really think there's a need for more trials that focus on implementation science and effectiveness. And we didn't talk about E2E trials or efficacy to effectiveness trials, which were a topic of interest a few years ago, perhaps less talked about now. But I think this is an area of pretty urgent need. And then this is the team that worked on all of the various studies that I showed here, one of whom is going to be talking in just a few minutes. So thank you.
Fantastic. Thank you very much. Please stay up here with us for the panel later on. All right, fantastic. We're going to move on now to statistics. So we have Mike McDermott from University of Rochester, who is going to be speaking to us on N of 1 trials for personalized medicine. Thank you, Mike.
Okay, thank you for the invitation to present. I was tasked with talking about N of 1 trials. Well, there we go. And there's been growing interest in the area of personalized medicine, particularly in the last 20 years. And first, my disclosures, of course. So what do randomized trials have to do with personalized medicine? One could argue not a great deal. Randomized trials generate knowledge about average treatment effects, at least in terms of the traditional design of these trials. So questions arise. Do the results of such a trial apply to the individual patient? Which treatment is best for the individual patient? It's relatively rare to have trials that actually compare existing treatments head-to-head as opposed to versus placebo. And do the treatment effects even differ among patients? Is there heterogeneity of treatment effect, or do all patients respond in a similar way? Again, traditional trials don't really address those questions very well. Subgroup analyses in these trials can help a bit. They can determine, for example, if average treatment effects differ among subgroups of patients, but still not geared toward necessarily the individual. So that's where N of 1 trials come in. And what is an N of 1 trial? It's specifically designed to determine the merits of a treatment for an individual patient, and it involves periodic switching of treatments. Usually 2 treatments, but you could do this with more than 2. Switching those treatments over multiple periods, not just 2. And ideally, it involves the randomized order of these treatments. So when are these trials most appropriate? There are certain conditions similar to those you might see in a crossover trial. So for example, a chronic stable condition or a frequently recurring or relapsing symptomatic condition would lend themselves to such trials. Also, the kinds of treatments you can study. You'd want a treatment with a relatively rapid onset of effect and also a rapid loss of effect upon the withdrawal of that treatment. The treatment should offer a short-term relief of signs or symptoms and not be a cure for the condition. That's really not the intent. And really not appropriate for rapidly progressive or self-resolving conditions. I guess an exception to that might be if you've got a stable condition within a progressive disease. For example, looking at dyskinesias, treatment for dyskinesias and Parkinson's disease might lend itself to an N of 1 trial. The history of these, I think back in the early 1950s, this is the paper that's most cited as being really the first where the N of 1 trial concept was brought to the attention of a broad clinical audience. This was published in the British Journal of Preventive and Social Medicine, and it involved the study of somebody who had, I think it was some thyroid condition. I have to go back and look at the paper, but it's sort of interesting that it took 30 more years before, the idea really was championed by Gordon Guyatt and his colleagues up at McMaster University. So this group really set the ball rolling for a lot of work on design and how to analyze data from N of 1 trials. And you can see the series of papers that are listed here. And how about in neurology? Probably most commonly, you would see N of 1 trials in conditions like ADHD and various pain syndromes such as osteoarthritis. There's a nice paper by Bas Studenberg and some of the MSG members, Jeff Statlin, Birch Griggs, and others, Emma Matthews here, that participated in that. It was an N of 1 trial actually in many people, so an aggregated set of N of 1 trials looking at dystrophic myotonia and maxillatine for treating that. But more generally, Bas did a systematic review published a couple of years ago in Neurology and identified about 40 trials, I think, in the literature, 40 papers that reported the results of N of 1 trials or a series of N of 1 trials in a multitude of conditions. But one of the observations he made was that the quality of the studies and particularly the reporting of the results of the studies was relatively poor. Now, he also made the point that it's probably relatively few trials that get actually published compared to how many are actually done in practice. So he called this maybe the tip of the iceberg, but maybe there's a lot more going on in neurology than are being published. So what is an N of 1 trial in terms of the typical design? So you would have different treatment periods, as I said, and more than 2. So you can see in the diagram here that there are a series of A and B, treatment A, treatment B, and switching between treatments in hopefully a randomized order. So you have repeated outcome measurements, not only an outcome measurement in each period, but possibly several outcome measurements within each treatment period. And at the very end, of course, you have the ability to actually analyze the data, even though the data are only coming from one person, and that's the purpose of the replication that you see here in the design. And then, of course, importantly, you want to give feedback to the individual patient and make a decision about how best to treat that patient in terms of the treatment that you're studying. So the different components of this, randomization, of course, is an important component of any trial, and there are various ways of doing this. A very simple randomization plan can lead to time-dependent confounding. So, for example, you wouldn't want, if you had 8 periods, the first 4 to be treatment A and the last 4 to be treatment B. This other one, AB, 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 is also not desirable in case you have something cyclic going on for potential confounders. So what's typically used in terms of randomization is this block pair design, where after every 2 treatment periods, you have one with treatment A and one with treatment B, but in a randomized order. So that minimizes the effects of early withdrawal. So for example, if the first 4 treatment periods were treatment A and the person dropped out, you don't have any experience with treatment B. So this sort of protects against that. One of the downsides of this is that the small block sizes could lead to unblinding, but of course you don't have any obligation to tell anybody what the randomization design is actually, so that you can minimize the chances of unblinding. There's also some people think that maybe balanced sequence assignment instead of randomization might be better if you have relatively few treatment periods. So maybe having A, B, B, A, and having everybody go on that sequence. I think that most people would prefer randomization, but that opinion has been put out there in the literature. For example, I guess that if you're going to randomize with just 4 periods, you wouldn't want A, and B, B, for example, so maybe something more systematic. Other features, of course, blinding. It's not always feasible, particularly in clinical practice, which is where N of 1 trials might be most commonly done. It's not the case, but in principle they could be. So you try to do the best you can in terms of blinding, maybe blinding at least outcome assessors, for example, if you can't blind the patient, but you might blind the clinician. Washout periods, of course, are very important, and you have to be judicious in terms of how long these are, because you have multiple treatment periods, and between each treatment period, you'd want to wash out the effects of the previous treatment. So those need to be short. There are possible ethical issues of administering no treatment in the setting of existing treatments. It reminds me of some studies of dichlorphenamide and periodic paralysis that we did back in the late 1990s. And a lot of the people who enrolled in that trial were receiving treatment already, even though, you know, a randomized trial had never been done to show that dichlorphenamide had been effective, or acetazolamide. Some people came in to the study on these treatments. And so what we did was we randomized people to start with dichlorphenamide or placebo, and then had a washout period, and then switched the treatment in the second period. But in that washout period, what we did was we put people back on the treatment they were taking when they first entered the study, you know, before they entered the study. So it's what's called an active washout. And the important thing is we're trying to see if dichlorphenamide would reduce the attack rate in terms of the attacks of periodic paralysis. And what we did, we measured the attack rate over a period of 8 weeks. We only used the data from the last 2 weeks of that period in the analysis, because that gave enough time during the actual treatment periods for the previous treatment period or the previous active washout to actually wash out those effects. So that's one way to deal with the problem, and that's why I refer to down here as the downweighting of the observations in the beginning of a period if you have to use an active washout. Systematic outcome measurement, of course, is very important, and particularly given that you have, you're trying to make a decision about treatment for the individual patient, taking into account that patient's priorities in terms of the goals of the treatment. In terms of outcome measurement, this can be enhanced by, you know, latest developments in terms of remote monitoring, having diaries on cell phones, using things like actigraphy, depending upon what you're measuring. Things like heart rate, blood pressure, blood glucose can be done remotely. There's also the possibility of ecological momentary assessment, where you can prompt somebody over the cell phone to, this is the time when you need to fill out this particular diary or something about your symptoms. So that can all be done remotely instead of having people keep coming into the clinic. And it can enhance the quality of the data that you collect. And I want to emphasize the importance of replication in an N of 1 trial. That's really the purpose. You can't really determine the statistical significance of a treatment effect with just one patient unless you replicate. So you have to have not just treatment A and treatment B in a crossover study, but multiple replicates of both treatment A and treatment B to get some measure of variability of that effect across time. So multiple exposures to each treatment. And you can think of those replications as being the analog of a sample size in a traditional clinical trial. Instead of having multiple people, you have multiple periods. And you can increase power and precision to a desired degree by increasing the number of periods, increasing the length of each period, or increasing the number of observations that you take of the outcome within each period. And of course, you have to balance all of this with the feasibility of being able to do this, but it also will depend on how much the outcome varies over time. If you've got a noisy outcome measurement, then you probably do want to take multiple measurements of that outcome within each treatment period. But if it's a relatively stable measurement, you know, perhaps that's not necessary. In terms of analyzing the data more formally, you have to be aware of certain things. For example, you might think that you have a chronic stable condition, but sometimes there are time trends that you have to take into account. Hopefully the design in terms of washout periods and such will take care of the carryover of treatment effects from one period to the next. So, but that's an important component of the design that you have to pay a lot of attention to. Probably the most important thing in terms of analyzing the data is recognizing that these are data being collected within the same person. So they're not independent measurements. The closer two measurements are together in time, the more highly correlated they're going to be. And so one has to take that autocorrelation into account in the analysis. And there are various ways of doing that I'll talk about or I'll mention. Also, you have to deal with, as in any clinical trial, missing data, people dropping out, ending treatment periods early, and so forth. So those are always issues that come up. But statistical methods such as mixed effects models, Bayesian hierarchical models, time series analyses, particularly if you've got many measurements over time, perhaps even continuous measurements over time, then you have to get a bit more sophisticated with the kind of modeling that you do. But in terms of presenting results to patients, you don't want to throw p-values at them, obviously. You're going to make a decision about their treatment. So I have to stop in a minute. I will. So the emphasis really is on description and graphical presentation of the results to patients. Multiple N of 1 trials. So as Bas Schoenenberg and his colleagues did, they aggregated the results of multiple N of 1 trials together to come up with not only a statement about what the value of the treatment is in a population, potentially, but also within individual patients. And if you want to make a statement about an individual patient's treatment effect, then you can borrow strength from the experiences of other patients, particularly if there isn't a lot of heterogeneity in the treatment effect among those patients. And this would require smaller sample sizes than traditional trials, but the planning is a little bit more complicated because you need to have information on both within patient as well as between patient variability in order to plan the study well. But it does give you the ability to answer the question, is there evidence of heterogeneity of treatment effects between individuals? And just an individual traditional clinical trial is not going to be able to answer that question. It's only replication of the treatment effect within individual people can you answer questions like this. Is there really heterogeneity in treatment effects? And identify, if you do find that, you can identify characteristics of individuals perhaps with better response to treatment through these sorts of designs. But of course, you have to have a common protocol for all of these N of 1 studies, not hopefully done within the same organization. So the last slide I'll have is just to talk about a couple of additional issues. Reporting is a big deal because, as I mentioned, there are findings that reporting has been rather poor in terms of the quality of N of 1 trials. And so there is a consort extension for reporting of these studies, which is very helpful. And why do you see not too many of these published or carried out? It's because it seems simple, just do an N of 1 trial. There's only one patient, but you still have to have the infrastructure to do that. I mean, if you think of a drug trial, for example, who's going to produce matching placebos for one patient, right? That's kind of hard to do. So having platforms or services established at institutions for planning, execution, management, and analysis, and of course funding as well, those are barriers that have to be overcome, and there's a movement to try to increase infrastructure among institutions for doing these things. But it's very uncommon in practice compared to academic settings, but still relatively uncommon even in academic settings. So I think I will stop there. Thank you for your attention.
Now we're going to have Dr. Vino Vivek from University College London, Queen Square, talk about greener clinical trials.
Okay, thanks, Mike. I'm just going to whiz through this so we can catch up a bit of time. So I'm Vino from Queen Square in London. So greener clinical trials, talking about the sort of environmental impact of clinical trials. Why is that important? You know, we know that healthcare and climate change are interdependent. And healthcare overall accounts for 4% of the carbon emissions in total. And just last year, 40,000 new clinical trials were registered on clinicaltrials.gov. So, clinical trials makes up a significant portion of the healthcare contribution to carbon emissions. And just to put this sort of in a context that we can appreciate, one trial is estimated to make approximately 2,000 tons of carbon emissions. And so we flew over to New York 2 days ago now, and that's about 1,218 trips, which equates to one trial worth. So it's quite a substantial amount of emissions. So it's worth thinking about our sort of impact that we do, and it's something that we've started thinking about more and more in Europe and UK. It's not currently sort of considered and regulated as such. So recently there's a sort of low carbon clinical trials group in UK, and they've done some carbon footprinting of clinical trials, which has been quite informative. And so this is a trial of sort of stroke, intracerebral hemorrhage, and the total carbon imprint was 765 tons for the whole trial, and that's quite a lot, but it's a large multi-center trial across 10 countries from 122 hospitals. But the largest proportion of emissions comes from the clinical trials unit, so the location of where the trial's done. And similarly, a different ICH-based trial called Restart had 109 tons, which is a slightly smaller trial, only based in UK rather than a multi-centered international trial. And similarly, again, the CTU emissions were the largest proportion of the contribution, and other parts of the trial were sort of smaller contributors. So just skipping ahead to sort of imprinting or printing a neuromuscular disorder clinical trial. So this is our trial that is a neuromuscular trial in non-dystrophic myotonias that was supported by the Muscle Study Group. So we carbon printed this trial to get a sense of what a sort of smaller neuromuscular trial's carbon imprint is, and not too bad really compared to the larger multi-center trials, but this is a single site clinical trial of a much smaller proportion of 60 patients, and we the carbon output was 7 tons, which is 5 flights from London to New York. But looking at the breakdown of where the sort of carbon emissions come from, it's comparable to the other neurology trials. So the trial site, the CTU, is the largest contributor of the carbon emissions. So, the neuromuscular disorders, we're still sort of in keeping with what the other carbon printing studies have found. And just to show you sort of what that kind of means, the trial site, it's things like commuting for the patient visits, the other big aspects of the international shipment of the samples, storage of the samples, particularly in ultra low temperature freezers, meetings, site visits, etc. So they're the biggest contributors. They were based on that paper, imprinting the neurology trials and also some other trials from CTUs. There were some recommendations to consider when designing your trial. Thinking, I'm just going to point out a few in the interest of time, but things that I thought were quite interesting were, for example, there are these net zero taxi companies for patient visits, for example, which is quite an interesting possibility for our patient visits, reducing and considering, in-person visits if possible. Something that UCL has implemented is reducing the temperature of the ultra-low freezers from -80 to -70, which does reduce energy consumption, and there are other recommendations there as well. There are some published recommendations. Now, these are the UK ones. They are a bit old now. They're from 2019, and they're currently revising some. And but actually, the important thing is really to consider the sort of carbon printing aspect and thinking about the environmental impact of trials when you're designing your trials, which traditionally we really haven't thought about. Thank you.
Now we're going to talk about trial delivery and logistics. Dr. Matt Parton.
Hi, and the appropriateness of the guy doing the delivery and logistics talk, bringing a chair up, is hopefully not wasted on you. I thought this was going to be the awkward one. So that's me. Those are my disclosures. One slide, 5 minutes, 4 emojis, quite a lot to talk about. Like I say, this is the awkward stuff. If you could move the thing down, you'll see there's that there. There we go. So it's just there. So that was me. Oops. Go back. Yeah, that was me when I realized we didn't have enough chairs. So there we go. So it's moving on. You know neuromuscular diseases are rare, and to assess them and to see the change of a trajectory is complicated. If we were cardiologists or diabetologists, we'd have much more common conditions. If we were just measuring the blood pressure, we'd have much easier outcome measures that would give us a figure really quickly. You might not have been a trial investigator before, and you might not be in an organization that has got trial experience. And as an Englishman standing in front of a load of Americans to say, think about being a pioneer, because it's not difficult, is a bit awkward. It's always easier if somebody else has done it first, and you can sort of follow on to that. The next thing is, you probably didn't design the trial protocol, and there's lots of things that spin off this. What are the inclusion criteria? Are you going to be able to recruit enough people with people you've already got with the condition that meet those criteria? Is that recruitment competitive? Because that center somewhere that's faster and bigger and whatever may get all the slots, and the patients you were waiting to put in may not make it. What's the duration of the trial? What is the treatment interval, and how variable is it in the protocol? Again, I'm a European talking about vacations, but one of my colleagues realized he couldn't go on holiday this summer because he timetabled patients every week with no option of moving them all the way through. How is the IMP administered? Oral medication is easy to pass on to people to get them to take it if they can swallow. But if this is an intravenous product, who cites the line? Who's going to get the line in if it's difficult? I've been doing the nusinersen work as part of the SMA treatment in London. Intrathecal medication is difficult, and we had to work out how to do that. What assessments are going to take place? What assessments are going to potentially generate more work? Another ECG, another blood draw. So with all of this, think and be honest to yourself how much time you can spend on this. Who can help? Who's funding this? We've already had the very reasonable point that margin is a big deal, because if this is able to fund a research nurse, a fellow, of somebody else to spread the load, then it is so much easier. So basically, many hands make much lighter work. When it comes to patients, they need to understand the implications and commitment of joining a clinical trial. And what I say to them is basically, you're an experimental subject. You are not getting early access to a guaranteed cure. You may be on placebo. There may be side effects. We are often dealing with conditions that are disabling, with people who are really limited. Travel is awkward. How are they going to get to the center? Are they going to stay over? Can they park? All these other really sort of, quite tangible things. We've got a separate section on children because I only deal with adults, and at least that's I'm only dealing with the direct conversation. It's not on behalf of somebody smaller and younger. What would you do if the trial terminates early? Some people feel really let down. They've been saving themselves up for something, and then it goes. We started this morning with Dr. Parsons asking us, are we primary care physicians, or are we primarily focusing on something else? Are you only going to do the trial, or are you going to look after the patient? Because you may have people whose trial assessment interval is much shorter than their regular follow-up appointment, in which case they're going to start looking at you. Consider all of that and try not to be put off, because we've got diseases that could never be treated before. We've got diseases that can be treated better, and without the trials, we're not going to find out. Thank you.
Okay, thank you, Matt. And next up, we're going to be hearing from Kathy Matthews from University of Iowa, speaking on recruiting and engaging pediatric participants. Thank you, Kathy.
Thank you, and I extended the title a little bit, but I will be very quick. And what I did not include disclosures, because what you're getting is my opinions, comments. So I'm including retention, recruitment, and special considerations in pediatrics, but that is the wrong way. The other button. Okay, I'm doing better now. So recruitment and retention. We have a ton of experience with pediatric neuromuscular trials. This was a list off the top of my head of pediatric neuromuscular trials I could come up with. And we all know that treating children is, for many of our diseases, the best shot we have at improving long-term outcomes. So we need to be able to treat children, and we have a lot of experience. So this is not uncharted territory. Challenges in recruitment, retention. Matt just mentioned rare diseases in adulthood. Pediatric neuromuscular diseases are uniformly rare. So you can do innovative trial design, you can do multiple sites. Multiple sites results in decreased consistency in outcome measures. They're very expensive. I hadn't thought about the carbon footprint for both of these, but or you can support travel to a few sites. You're going to have cleaner data, but there's a huge caregiver burden for cost and time away from home. Children have time away from home. Caregivers have time away from work. When you're dealing with children, you're not just having one patient who needs to get there. You have a parent and the patient. The challenges of traveling with a child who may be fragile. And then because of all of those things, there are major equity and generalizability problems. It tends to be the people with more resources who are able to participate in these pediatric trials. And there are a lot of solutions under development, including things you've already heard about today, like remote participation. Things that facilitate recruitment, retention. Families and children are often highly motivated by the possibility of treatment, and as Matt just mentioned, this requires careful counseling. You have to talk to them about the nature of a therapeutic trial, that this is not a guarantee of treatment. Things that help are getting information from a healthcare team that you trust and know. I just note that it's very hard for a busy pediatric neuromuscular doc who sees every kind of disease, to tell every patient about any clinical trial they might have access to. So part of my spiel goes into the after visit summary, clinicaltrials.gov, look every 6 months. You may know about it before I do. I'm happy to talk to you about it, a trial that I'm not doing if you're interested. And then active patient groups, often for rare diseases, these are Facebook groups, but they can really be helpful in facilitating recruitment. Children are highly motivated to continue in trials by toys and money. I had a 12 to 13-year-old guy who was finishing a trial. I said, would you be interested in being in another one? And he said, yes, I want to be in the next one I can, because I've been saving all the money that I've gotten for buying a Switch or some such thing. And I need to be in another trial in order to buy my whatever it was. So we're trying to find one for him. So the more interesting thing is the special challenges and considerations if you're including children in trials. So the most challenging, and there's a lot of work being done in every field, is how do you manage developmental progress? You need different outcome measures for different ages and developmental stages. You have brain maturation. We all know a toddler runs differently than a 5-year-old and a 10-year-old. You have changes in coordination, and that developmental progress can mean that the trajectory is not one of steady one direction, but instead a period of improvement before decline. And this includes even when you're doing something like manual muscle testing or myometry. So this is just some of our data that shows that this is 0 or 5 to 19-year-olds. The blue line is one genotype of LGMDR9, and the red line is the biceps myometry score for people who are homozygous for the common mutation. And you can see that through adolescence, the homozygotes are gaining strength, while the other mutations are losing strength. In the adults, if we go to the 19 to 70, they are all declining. So this makes it very complicated to do a clinical trial design. Tolerability and risks of the outcome measure. Is it invasive? Does it need sedation? You have to consider blood volumes if you're dealing with small children. Assent and parental consent are more complicated than they are in a competent adult. Parents might not necessarily agree about participation. What do you do when the child doesn't want to participate and the parents do want them to participate? And then the area of newborn screening and broad genetic testing that's leading to diagnosis well before symptoms in some case, and clinical trial design needs to be prepared to undertake those challenges. So I said I would whip through this. Thank you very much. And I know there's a lot of experience in the room that we hope we'll have time for further discussion of PEDS trials. Thank you.
Thank you, Kathy. So our final speaker for the session is Merit Kajauchwich, who will be speaking today on starting a platform trial, helpful tips. Thank you, Merit.
And thank you for the chair. I was trying to figure out what I was going to do. I was planning to stand. Anyway, I'll be quick. So I have a couple tips on platform trials. So we're seeing in neurology a real growth in this concept of platform trials, which has been done really successfully in cancer. I think there's over 20 groups I've counted that are at least either in the planning stages or running platform trials. And we're seeing federal funding more for this as well. So I'm going to talk a little bit more about the ALS one in my at the dinner talk, but I wanted to share some of the things that we learned in trying to get this set up. And so these are the 5 topics. The third one, getting the funding, is probably the hardest, but sometimes you're lucky and sometimes you have to work very hard. So I'll just say the first thing when the ALS field was trying to think about whether we should do a platform trial, was trying to figure out if we were ready. And this was with the NEALS, which is a similar group to this for ALS consortium. And we invited, I think 4 or 5 statisticians from different platform groups that had already done this in cancer to come to our annual meeting and hear from us the state of ALS, the science as well as the outcome measures, the network, and then for us to hear from them about how they set up their platform trials. And that was an all-day meeting, and at the end, they pretty much told us we were ready. They said, you have all the things that you need to do a platform trial, and that was, a lot of drugs in the pipeline, outcome measures, sites, kind of a network ready to do it. And we learned from them a lot about, how to set it up, what worked for them and what didn't work for them. And then we went and we spent 3 days at WashU with Randy Bateman and his team, who had set up the platform trial in dominantly inherited Alzheimer's disease. And they really shared, again, all their lessons. So it was really worth time really well spent to do that kind of homework. And then the second helpful tip is really getting everybody engaged. And this isn't unique to platform trials. It's probably for any big initiative you want to do. But we wanted to really make sure that people felt part of this. And so we started with patients, just to start to educate them about that and get their feedback on it. And from day one, we had a patient advisory group for the platform trial, which still exists and gives us enormous good advice and has really been the reason why enrollment in this platform trial has really been off the roof and much faster than other kind of standalone trials. Then we went to industry and we had a 2-day meeting where we invited every company that had a drug in kind of phase 1 or ready for phase 2 testing, because we designed this as a phase 2 platform trial. And so there were about 25 companies, and we talked about our design, we got their input, but we engaged them before we had finalized things, which I think in retrospect was very helpful because they felt like they were a part of this. And we got to hear from them what they were worried about, which was mainly around kind of the loss of autonomy, perhaps, and a little bit about the data sharing and access to their data and not being able maybe to change everything the way they might want when they're really working as a group where in order to be able to share the placebo across groups, you really had to have a lot of things similar, but and really talking through what could you change and what you couldn't. And then we went twice to the FDA, once just the kind of investigators designing it to share what we wanted to do and get their input into it. Because again, back then, it was 2018, while they knew some about it, it was still relatively new for the neurology branch. And then we went a second time with our first 4 companies, and it was one of the first times that in the same room you had multiple companies talking about the platform. And really from day one, the FDA was very engaged and excited about this. And then we also went to the foundations, the same thing. We, all the foundations in ALS, the major ones, have contributed to this, and we created kind of a committee of foundations, so they felt part of it. They could tell the patients about it, and they contributed to it. And then we spent a lot of time with our network, really just talking about platform trials and getting them excited about it. Someone, I didn't know Ted Burns said keep it simple, but that was the advice we kept getting. Like, don't go like global, don't get really complicated in your adaptive design. Try to start with a simple platform trial. You can make it complicated later. So even though this looks like a lot of boxes, it's actually a nimble, small group of people that have different roles. And it was a way also to really engage our NEALS network. So there's some members who are on the design committee that meets weekly. There's other ones who help run it. There's a group that picks the drugs for us, and then we have small task force around outcome measures and recruitment and retention. And basically anyone in the network that wants to get involved can get involved. And then for each drug, and we call them regimens, where there's a steering committee, and we again try to get new people in the field to be on those steering committees. And we kind of have a path, like if someone's on the steering committee, then for the next drug, they can maybe be a co-lead and help run it as a way to kind of train the next generation on how to run trials, so that every regimen is run by 2 people, an experienced one and a new one, and then we have members on this steering committee. And as I mentioned, we have this patient advisory committee that meets quarterly, and anytime we have an emergency where we need a question that we need input from patients, they help us. And then we meet also quarterly with anyone who's given support, financial or in-kind support to the platform trial. So that's how we kind of engage our network on it. One of the things the patient advisory group told us from day one was that a lot of patients want to be in trials, but they don't know anything about it, or they feel like maybe they enroll in it and they don't know anything that's happening. And of course, we can't say very much that's happening during the trial, but what we did was create, every Thursday, 5 to 5:30, we have a webinar about the platform trial. And we always get new people, so we have, we're always talking about the design, and then we answer questions. We'll invite, sites to come speak about how they enroll. We'll invite, anytime we have a new drug, we'll have a webinar about the science, and then we record that and post that. So it's a way really just to get the word out. And then Catherine Small and Allison are our patient navigators, and people can call them if they want to find out more about it. And they also help people find centers. Like, for example, we have 3 or 4 centers in Philadelphia, and some of them are full and some aren't. So they'll help people kind of go to a different center if the one where they're getting their care is full. And actually our sites appreciate that because they are themselves overwhelmed and can't really do that kind of navigation. So those are the first 2 things about kind of just, if you're going to do something this large, really, and you want a network to be behind it, is really getting people excited about it and feeling like they're part of it. The securing funding is, I think, one of the biggest barriers to getting a platform trial off the ground. And again, we were very fortunate that while we were thinking about this, a patient of mine, Sean Healy, came and said, you have about 24 hours to give me a proposal, show me that you can work fast. And we had been thinking about this, and he funded, with his friends, about half of the cost for the first 4 drugs. And that was all happened very fast. And so we made it a competition for the first 4 companies to apply to be part of the network, part of the platform trial. And that's how we were able to really get this whole thing off in about a year's time. But I know that that doesn't happen very often in one's life. But there are other ways. I mean, there's a PSP platform that was just funded by the NIH. There's Alzheimer's ones that are funded by the NIH and stroke. So but that's something you have to start working on quite early on. I talked about keeping it simple, and I think the other thing is really about sharing what you learn, and we learned so much from Randy Bateman and his team, and they were very generous, and that helped us go faster. So we've published the design of the platform trial, the master protocol. It's all a free download. Nice thing is that Annals didn't charge us for any of this. And then we also have a companion article which only Mike McDermott in the room and other statisticians can understand, which is all on the analysis of it. And then we're about to have published it's under last review, the results of the first 4 drugs, which I'll talk a little bit more about this evening. We've talked to lots of groups, so that's at least 14 there, most of them in neurology, some not, all who are interested in doing platform trials, and we've tried to do the same thing, that people come and they spend 2 days with us and our team, and we share what we learn and what we would have done differently. And I think that's my last one. So,
Merritt, come sit over this side. And thank you so much. So everyone's got a chance now really to pick our expert panel's brain, and we've really got an amazing panel. So questions? Valeria. Gil, can we get a microphone out here as well? Oh, fantastic.
Okay, thank you so much. Regarding the platform trial, I may have missed the part of the competition between the pharma. So how do you see the pharma coming in, and why should they come in and share their protocols and drug experience with the others? I mean, what is it that's making them competitive and want to come in? I missed that.
Oh yeah, so for the first 4, there was many benefits. One is that half the trial cost was covered by the donation, so that was one thing. But that was really to jumpstart it. But what they gain is the overall cost is lower. The cost is cut by about a third compared to like doing a standalone, and that's because you're sharing the placebo data. You also have much faster startup time because this is one protocol, and every time you add a drug, it's an amendment. So it's 30-day FDA review. Our IRB, central IRB, is about 9 days. So you're not doing a 12-month startup, finding your sites, contracting. So the time, time is about cut in half, the cost of the third, and the patients want to be in this study. They don't want to be in a standalone trial anymore. So the 5th to 7th drug, they pay their entire costs, but they still benefit from the efficiency and that the whole machine has been built. Sure.
The clinical heterogeneity of clinical trials is a major issue with, how do you think we can, is it AI, or how do we kind of stratify and overcome that kind of issue to improve the outcomes in our trials?
Who wants that
one? Never be a pioneer. I think it's obviously easy. The bigger the disease, the more patients. I mean, I think the answer to that is numbers. And if we were cardiologists, if we were stroke physicians, then we just have the numbers, and the heterogeneity just gets diluted down. And I think the difficulty we have is rare diseases with few patients, and heterogeneity gets magnified. And I think it's just meeting that head on. So I don't have an answer other than just got to work around it.
Sorry, no, this is for Mike. So the N of 1 trials, I'm ignorant, but if I understand from how you explained it and how it is, it's very hard to think, as you said, to have placebo drug for just one patient. So what I understand and my conclusion is that you can apply an N of 1 trial with either drugs that are needing to be repurposed, or you want to try something like that, or how can you think of an N of 1 with a new drug that you want to know who will fund for this? So it's as I see it, it's going to be like trying again or confirming some results from another trial, like it has been for the mexiletine, for instance. Or if you have two drugs, you can do head-to-head and short duration, but it will never be for a new drug. Is that right?
Search me. So yeah, I think that one could think of, I mean, if there's somebody who wants to develop a new drug, then I suppose that it's not really in the company's interest to manufacture new placebo, but maybe they're doing that. I mean, one solution might be if you just could get drug from them, to make your own placebo and to encapsulate it if that doesn't change the bioavailability of the agent. But I think most of the time with N of 1 studies, you're really thinking about the individual patient at the time and you're thinking, what of existing treatments can I use? Like, you know, to your point, I think that it's much more commonly done with things that are already out there rather than something that's newly being developed.
Thank you. It's a question for Gordon. You mentioned at the end of your talk about implementation science and how we need to be looking at that as well. Are there examples that you know of in our field and interests where either there's been hybrid with efficacy and implementation trials or pure implementation trials? Because I think that probably is an avenue, but probably for us as a group, we're not so savvy or understand some of the implementation science elements just yet.
I think that was for me. I can't think of a neuromuscular combined efficacy or efficacy to effectiveness trial. Maybe someone else can. Yeah, go Rick. Rick's going to answer your question. Or what was that?
Examples of implementation science. This is not our bailiwick. We don't know how to do implementation science. It's a whole field. So I recently partnered with Ann Sales from Michigan, who's an implementation science guru, and we just submitted a grant. We'll see how it does to PCORI. And so it's to she took the pains controls concept, and we're going to, the study is, they're going to randomize sites to either teach the patients about the various drugs for pain or to teach the physicians about the various drugs for pain. And we're going to look at the outcomes on pain scale of who has the best pain control, if it's the patients being taught or if it's the doctors being taught. And we'll see what happens. I haven't had a grant funded in 4 years, so maybe. But that's an implementation science, because that she came up with that idea, and I said, okay, let's try it.
So if you consider, some of these factors that first the FDA really likes patient-centric measures, we now have things like home phlebotomy, obviously the things raised about greener clinical trials with carbon emissions. What do you see as a panel being the biggest barriers to us developing kind of fully remote trials, or at least selected fully remote trials?
First of all, hi, Shifu. Good to see you. I'm with you. I think that we have to move that way, and that will help with also access and equity. I think the challenges are having good enough outcome measures that can be done remotely, whether it's going to be the digital ones or done by phone. And then also this idea that it might lower cost, I'm not sure how true that is, because especially if you need nurses or other groups going to home, it actually ends up being very expensive. So I think we have to move there, but there are barriers around, how do you find them, and do we have enough outcome measures to be valid?
Yeah, one of the lessons we learned, or we're learning in remote CIPN, which is it's centralized, decentralized, right? The therapeutic agent is a group of nurse practitioners in Salt Lake City. We're gathering the data remotely. That's easy. The problem is every time we add a new nurse practitioner, every site needs to credential them. And so the IRB is no longer the rate limiting step. I mean, our credentialing office takes forever. So there's a lot of logistics that go if you're going to centralize components across a highly decentralized network that are not things that we normally think about in clinical trials. At least that's and that was an N of 1 experience.
Not randomized.
Okay, so I think we're out of time for questions. I want to thank our panel for participating in this trial session. And we're gonna welcome up Dr. Chad Heatwall, professor at the University of Rochester, to talk about late-breaking trial Starfish.
Thanks, Mike, and thank you for the selection committee for allowing me to speak about this topic. This is the Starfish study, which is a study of testosterone in HGH and FSHD. Yep, no problem. So those are my disclosures. And my other disclosure is I'm the director of the Center for Health and Technology at the University of Rochester. Dr. Mike McDermott also has an appointment at that center. There's 6 units that's been operating for about 30 years. We run multi-center clinical trials with industry and academic groups. We also ship drug, including drug for the Healy study. We have a big data analytics. We have an innovation that does remote trials, outcomes division, and a health equity division. So we've run over 150 trials, 45,000 patients. We've developed over 200 outcome measures, and our studies have led to 12 FDA drug approvals. So the Starfish study was also part of Chet's, and it is open label study of testosterone and HGH for FSHD muscular dystrophy. This was open label. It was investigator initiated, with the primary outcome measure being safety and tolerability. But as with many studies, of course, we're going to measure strength, function, muscle mass, and disease burden as measured by our disease-specific patient-reported outcome measure, the FSHD Health Index, or FSHD High. Many of you know what FSHD is. I won't talk too much about it. It has a prevalence of 4 out of 100,000 people. It's dominantly inherited. And there's no proven therapies to treat weakness, muscle atrophy, or functional decline. There's a recent setback in genetic therapies this month, actually, for this. The other important point is there's no known malignancy with this condition. So combination therapy has never been studied before the study in muscular dystrophy. It has been looked at in healthy adults and elderly adults. And combination, I define it as testosterone with recombinant HGH. Our objective was really to do this pilot study with testosterone injections every 2 weeks and daily recombinant HGH. So again, there's some justification. I won't go into this. There are animal models and also some smaller trials of singular agents. And then in healthy adults, it appeared to increase strength and muscle mass and aerobic capacity. And so the theory is if this also has a similar effect in FSHD, maybe we can allow patients to walk longer, continue to maintain their muscle mass, regain their strength, and potentially regain their function. So the trial design was a single arm, like I said, proof of concept study. Patients received study drug for 24 weeks, followed by a 12-week washout period, serial safety testing, extreme safety testing, actually. We had a very large committee to do this, serial laboratory testing, functional assessment, and disease burden questionnaires. Highlight outcome measures, again, always safety, tolerability, feasibility, but we looked at the following things as well. So what were the results? There's a 20-patient study. 19 patients completed the study. This was done in the context of the COVID pandemic. One patient dropped out due to distance and the COVID pandemic. No participant experienced a serious adverse event. One participant dropped out, like I said, due to travel. The most common adverse effect was soreness at the muscle injection site, either testosterone or HGH. 7 participants received that or experienced that. And no participants had difficulty administering the medication despite the hand weakness. Some participants got family members to do that for them. Okay, so this is probably my favorite slide. We really haven't seen this degree of therapeutic response in other therapeutic trials involving adult muscular dystrophies. This is a population that would be expected to lose function over time. They actually gained 37 meters in the 6-minute walk distance. We serially measured DEXA lean muscle mass. They gained approximately 5 pounds. They were instructed not to change their exercise during this period. They simultaneously lost fat mass at about 2.86 pounds. Their overall strength measured by QMT increased by 3%. Their lower extremity strength increased by 0.13 on the MMT scale. Again, clinically significant and statistically significant. Their FSHD high, which is a measure of disease burden, improved by 6 points or 19%. We've never seen that in any FSHD trial, and this instrument is in just about all of them. And the functional testing as measured by the FSHD-COM improved by 2 points or 12% from baseline. And there's a temporal response to this. You can see the baseline 8, 16, 24, and then they go on to a washout period. The one on the left here is a 6-minute walk. You can see even in the washout period, they lost some of that function, but they were still above their baseline. Similarly, the FSHD high gained function throughout and started to lose that during the washout period, but again was above baseline. And you may ask, is that clinically significant? 25 to 35 meters has been shown to be good, or MCID, for the 6-minute walk. So this is clinically significant. QMT, similar result. You see up to 3% with a washout, and MMT, again, up and then with some washout period. These are the graphs for lean muscle mass. You see that goes up, and fat mass goes down. With, again, a return to baseline, but not a complete return to baseline during the washout period. This is the FSHD-COM, again, dramatic results in this. And then it actually correspond with serum levels or IGF levels went up, which would be expected, also dropped during the washout period, and testosterone went up. And we think that there's probably an interaction between the recombinant HGH and the testosterone, which resulted in the last value being slightly lower. So again, relatively safe. There was a couple dose modifications based on pre-specified serum levels, but it was well tolerated. In conclusion, we found that this was safe and well tolerated. We didn't design this to be an efficacy trial, but the results were dramatic enough that they were statistically significant. We saw improvements in ambulation function, muscle mass, and disease burden. And certainly randomized placebo-controlled trials are needed to further investigate this therapeutic approach. I'm happy to report that we have a 1-year planning grant through the NIH to plan a definitive trial of this therapeutic intervention in FSHD, and so we're in process, and we'd love to partner with people who are interested in partnering with us to conduct this trial. So again, we're in this 1-year period. The next step is we're going to be partnering with NIH, foundations, industry, FDA, or multiple one of those entities, looking to collaborate with this. University of Rochester filed a use patent, And we're looking forward to this, and we feel like it's a viable or promising option for patients that otherwise don't have very good therapies. So thank you very much. And just one last slide. I'd just like to thank the group, University of Rochester. It took a village of specialists and endocrinologists and urologists and cardiologists to help with this. So I really appreciate your time.
I think we have time for maybe 2 questions.
Beautiful talk, beautiful study. Was there any association between degree of clinical improvement and quality of life measures that you did? Did you look at the convergence of the improvement?
Yeah, we did. So the functional improvement correlated with the measure of disease burden as measured by the FSHD high. FSHD high subscales also detected benefits in fatigue and whatnot. We interestingly also put in a PROMIS measure. Some of the subscales of the PROMIS measure responded, but the physical measure of the PROMIS measure failed. And so again, this is kind of a demonstration of why disease-specific patient-reported outcome measures are worthwhile and sometimes outperform generic instruments.
Thank you.
Could you speculate whether this is specific to FSHD, or you think this could be more widely sort of applied if other conditions were treated with the same?
So the benefit of this is not specific to FSHD, and I feel that this is an avenue that is potentially applicable to many of the muscular dystrophies, neurologic disease, atrophy of the elderly, sarcopenia of cancer, HIV. I think it has many potential implications because it is not a disease-specific treatment.
Thank you.
Yeah, thank you so much for the talk. I'm just wondering if this treatment in future trials is going to be only for men, or women are going to be included at some point?
Yeah, so excellent question. So we wanted to test this in men only first because we didn't want to risk women having bad side effects to the testosterone. But we are actually going to go back and do a dose-finding study in women with muscular dystrophy based on the results of this study.
Great, thank you, Dr. Heatwall. I just want to remind everybody after the break, come back. We're going to be having the industry sessions. We're going to hear about some exciting developments.